Beautiful, wasn't it? The entire video. So yeah, I was just saying, beautiful, wasn't it? This entire video. It actually, reminds me there's so much we can contribute, not only for this country, but for the entire humanity. So let's move ahead with our research day. The other day I was thinking, what is different about research in health professions education as compared to other disciplines? And I would just like to briefly share my thoughts with you. To me, it encompasses the uniqueness of the quantitative and the qualitative paradigms. I like painting, so it's just analogous to painting on a canvas, where with each stroke of the brush, you tend to choose the exclusive blend of colors. And that's exactly what happens in research related to health professions education. That the research outcome is that elusive blend of the two paradigms, which makes it significant, unique, and alluring. And guess what, ladies and gentlemen? Today, you will be witnessing this very unique blend, and you will be enjoying as well. Yes, I can assure you for that. Once we have our oral presentations beginning in a short while, and with that, we also, let me share with you, we also have our e-posters with us on display for the entire week. So you can actually browse and you're of first connect with the mentors and continue collaborating for research in health professions education. So that was a little bit sharing of my thoughts with you. So let's now invite the interim chair of the department, Dr. Mohammed Tariq, for his address.
Thank you, Sonia, for the beautiful words you've used in describing health profession education research. So on behalf of the Department for Education Development and the Medical College and also the School of Nursing and both the deans, I invite you, I welcome you all to this Education Research Day organized by the Department for Education Development. And this is the 5th one. And the idea is to disseminate educational research through all continuum of education, with particular emphasis on health professional education, including medical education, nursing education, as well as general education. There is some aspect of general education as well. So, health profession education is a rapidly evolving field, and continuous feedback through evidence-based research is needed in order to enhance the quality of education with respect to teaching and learning, with respect to education, with respect to curriculum development, faculty development, and you name it, in all aspects of education. And this is done through inquisitive inquiry and analysis of the educational aspect, with identification of challenges, development of strategies, with implementation, identification of impact of that implementation, followed by analysis of impact, and then identification of new challenges and development of new strategies. And this cycle goes on and on. And I think this is what we try to promote in this Education Research Day, which is now 5th in line. First 3 years, we had this Education Day face to face. Last year, it was the first time we organized this event online, and it was a huge success. People from all over Pakistan and maybe from outside as well, they attended this Education Research Day, and with good feedback. And this year we are doing it hybrid. As you know, COVID is currently is slightly lower in intensity, so we can at least do it. So today we are doing it a hybrid program, where a number of you are now invited physically in the auditorium, and more than 300 registrations we have received so far for this event from all over Pakistan, as well as from outside Pakistan as well. And the posters, you can see these posters from Monday till next Sunday. Everybody can view those posters. There are 71 posters online, and so far more than 250 views we have captured on these posters as well, and still we have 5 days to go. So that is the situation there with the posters. So far in 4 research days, more than 220 abstracts have been presented, and about 64 are published already, and a number of them are in review process. So I think that is again a dissemination of research which is going on. So I will not take much in my speech, because we need to hear president and the dean and the keynote speaker. So today, after this inaugural session, we have 3 sessions of 4 presentations, where scientific topics will be discussed and presented, followed by best poster presentations, and then best oral presentation, and then there will be a concluding remark. So, so that is the program today. So I would now like to invite, so just forgot to mention, research committee headed by Sonia Haider, including Dr. Rahila Ali Mazhar, Javeria, and then Dr. Tabassum, Dr. Shazia Babar, Anil and Sundar Miran. They are actively working with them, along with Dr. Leena Khan. They worked very hard to bring it together. And I think I was just facilitating things. I think these are the people, they really worked hard in organizing this activity. So really thankful to all of you. And I forgot if any name, I think, please forgive that. A person is the estimator of these things which we are actually doing, Dean Adil Haider, and always supportive of research. He's an icon of research, I would say. More than 350 papers he has published, and I think a number of grants, big grants from all over the world he has. And I think and all sort of a support for research and all the education, and full support for the Department for Education from his side. He's a professor of, for outsiders, he's a professor of surgery and community health sciences as well. Dr. Adil Haider, for your remarks.
Thank you so much, Dr. Tariq, for that very kind introduction. Dr. Tariq, of course, everybody knows, is the chair of the Department of Education Development and Associate Dean for Education. But most people online may not know is that he's also one of our most celebrated physicians. And I think it's one of those things where it just exemplifies how the best teachers are also those who are the best in our field in medicine, the best doctors as well. So that's a very important point. I want to begin by acknowledging the presence of our president, President Sulaiman Shahbuddin. I want to specifically point that this was scheduled probably before the president started, but when we just recently sent him information about this, he chose to be here and to make remarks, because he talked about how this is a very important event, because this is what is central to the university. What the university does, imparts education. And a research day devoted to the Department of Education Development just makes so much sense. So we're so grateful for you to be here. I want to recognize our keynote speaker, who we're looking forward to hearing from, Dr. Muhammad Al-Araki, who is going to join us virtually, and he will be joining us. He has an incredible CV. You're going to hear about his introduction in a little bit. But I also want to point out that along with him, we have now more than, how many do we have? 200 plus people online? Sorry, 300 plus of you have joined us online. So thank you so much for being here and being part of today's events. I also want to recognize, we've already talked about Dr. Sonia Haider, who who started off the day's events and who's the chair of the DED Research Committee. And of course, all the members of the committee and all the other colleagues who've put today together. As Dr. Tariq mentioned, this is the 5th installment of the DED's Research Day, and it's incredible to see the growth of your Research Day. I recall the first one that I came to in person, and this is now, in all counts, it's your fifth time, but it's probably 5 times bigger than when you started, and it's grown by incredible leaps. And one of the main reasons why that has happened is because educational research is finally finding its footsteps, its foothold. Previously, educational research just did not have, I think, the sort of critical mass to really take off and have people identify themselves as education researchers. There were people who were doing education research, but as its own field and its own entity, it's gaining in steam. The number of publications, for example, if you go to any big conference, the number of publications for used to be basic science and outcome science, and now you see that educational research is its own thing, and it has a significant number of publications and so on. So I'm thrilled to see that you have so many abstracts and so many good oral presentations. I say this for a reason as well. I, as you know, have been getting involved with more and more education research, and I want to give a special shout out to at least 3 of my co-investigators who are presenting today. I know Namra is going to be presenting. I know Ali Ahel will be presenting. I know Maria Zaki will be presenting, and I am privileged to have the opportunity to work with all of you smart people on the projects that you'll be presenting today. So as any PI, I'm super proud of our research teams that are going to be presented, and I speak for all of the PIs who will have their colleagues presenting today about how proud we are for what you're doing. I want to make a few comments about how the DED and us in education research have had to pivot during the time of COVID. And I think the reason why you have named it Health Professions Education, Innovations and Research in the Era of Change, which is the tagline for this year's installment, I think it has to do with the fact that COVID, it has changed things. And if there were any successes in COVID, I think the way our educationists pivoted so fast was just truly remarkable. I recall, Dr. Roxana Zuberi is here. She's the forerunner of this department and helped establish it all. But you would have been so proud, Dr. Zuberi, of the people you've trained and how within days of when COVID hit, they were sitting there and if you would have seen how they managed the examination, like the whole new assessment technique, President Shabalini, if you would have seen how within weeks they had figured out a whole new assessment technique, and then they tested to make sure it works. It was just incredible. And I think that is something we need to keep on doing as we move on in educational research. A big challenge is going to be as we move on to all this online education in medicine, in nursing, and all these other fields, we have to evaluate every new method we're using. And I think that's going to be a huge field of educational research, to see all these new techniques and how they are going to properly impart the education. Up till now, we've done a lot of work to make sure all of our residents who graduate, they have the adequate caseloads and so on. But we must make sure that if we change the method of instruction, that we assess and make sure that we are providing better quality education, and that the doctors and nurses and other healthcare professionals who will come from that will do even better. So I want to just end with recognizing the rest of the committee that's here to put this whole thing together. Again, the Department of Educational Development has done just an incredible job on so many different fronts. They are the people that are in charge of all the assessments. They are the people who are in charge of doing creating that question bank. And even in the time of COVID, they have come up with new methods of assessment. I understand that by 2022, by next year, we've already started the examination system, which is now fully online. And by 22, we'll be almost fully into that examination system. That will be a sea change for the way we do stuff at AKU. And again, you'll see the Department of Education Development. And I see people from the exam cell here. You're working day and night on this. And I know that will be one of the ways the Department of Education Development continues to push us into the next century. So with that, I just want to again thank you and congratulate all of the members of the DED on very, very amazing work. Thank you so much.
So it's my pleasure to invite the president of the Aga Khan University, and we are fortunate that he is here today and he has taken time, full hour for this inauguration. So please for his remarks.
Thank you very much, Dr. Tariq, Dean Heather, for those generous remarks. Friends, faculty, colleagues, students, researchers, Assalamu alaikum, Karibuni, and a very good afternoon. And Karibuni is my greeting for my East African colleagues. So first of all, it is such a pleasure to be here. It is an honor. Thank you so much for inviting me. I was telling Dr. Tariq that a lot of this is new for me. So I'm learning each facet of it and I'm enjoying every moment of it. So thank you for the opportunity. You know, for me, I'm here really for one simple reason and purpose. And this is to encourage all of you to continue advancing the state of knowledge through research into all aspects of education, including learning, teaching, assessments, curriculum development, and program design. I want to recognize Dr. Tariq, the DED, and really your wonderful team. I know that you all are involved in the entire area of curriculum development, assessment, teaching, learning, and also you oversee the exam cell. So this is commendable, and this is your fifth event. So thank you, and well done. My hope is that we will all emerge from this symposium with commitment to building our own capacities and that of others to engage in innovative inquiry, to thoughtfully incorporate evidence-based findings into our practices, to share the findings of research widely, and to engage with policymakers and to advocate policy to create an environment in which educational research can thrive and make a difference. Indeed, today we are meeting at a remarkable moment in our times and really in history. We are living in an era of innovation in health profession education around the world. Interprofessional education and collaboration is gaining traction amidst the recognition that high quality care depends on collaboration between nurses and doctors and between the entire care giving team. Medical students are experimenting with different approaches to clinical education that de-emphasizes the rotational model that we have been used to, in favor of one that prizes continuity of relationships with the family, with faculty, and so on. Integration of specialties has become important, and many institutions are now experimenting with how to build integrated models where service, academic research, all of it comes together. Some other institutions are testing approaches that focus on the achievement of specific competencies rather than how much time students spend on specific subjects. High fidelity simulations is changing the way doctors, nursing, and caregivers are receiving their learning. And in this, the Arkan University has taken a major leap by establishing the Center for Innovation in Medical Education, both in Karachi and in Nairobi. And this is wonderful. I mean, I was so impressed to visit it the other day and to be told that this is the only one of its kind, not only in Pakistan, but it compares with the best in the world. So this is really fantastic. And of course, online learning and online teaching and online care delivery has become important. So this is again another area that we are grappling with. It's it's interesting that the whole online notion, the healthcare system has been late in accepting and in absorbing it. Many other industries have absorbed the online methodology much earlier than healthcare did. But COVID has shown us that we are really catching up, and this is an area which is becoming more and more important. We are living in an area of research in health professional education and education research more broadly. Since 1980, the number of journals focused on medical education has grown from 3 to 35. There are now roughly 90 journals that are focused on health professions education. In the last 20 years alone, the number of articles being published in the field has nearly tripled. It was not so long ago that the notion that every medical school should have a department of medical education was unheard of. But this is becoming common now. Everyone is recognizing the importance of DED and departments such as the DED. I know that AKU is working to launch a PhD, a doctorate in health professional education, and this is commendable. We're also living in an age of knowledge economy. The shift from the world of the assembly line worker to the world of knowledge professional is happening. The consequences of this shift on education are profound. Rather than taking as a model of factory, which is a place of repetition, schools must look for inspiration to the laboratory, a place of inquiry. Finally, and we know this, we are living in an age of the pandemic. As health professionals, you know, as well as anyone, the devastating consequences that the health systems of this world has seen, and all of us have seen. But as educators, you've also seen it spur remarkable feats of innovation in teaching and in learning. It is an exciting time, a time of huge challenges, of vast opportunities and rapid transformation. And yet, when we turn our attention away from higher education and the highly educated professionals, what do we see? We see a world in which things have not nearly changed as rapidly as we would have liked it to be. We see mothers and children dying from preventable causes every day. We see a health system that continues to struggle, especially in the countries and regions where we operate. Non-communicable diseases remains a significant threat. And our health system remains highly unprepared to deal with contagious diseases. In Pakistan, primary and secondary school, students are still not learning enough. 22 million children of school-going age are out of schools. Indeed, AKU's Institute for Education Development just completed a nationwide study in which students were only able to correctly answer 30% of questions on standardized tests in mathematics and science. And this tells us how much work, how much catch-up is required. So as we share findings and learn from each other today, let's keep in mind the ultimate purpose of research in education. And this is to deliver skilled professionals, to train skilled professionals who are ready to improve people's lives and improve the lives of institutions, improve the quality of institutions in the countries and regions where we operate. Let's harness our enthusiasm, our passion for creating knowledge to the great task of ensuring that everyone has access to high quality healthcare and education, and the opportunity to develop their talents to the fullest. So thank you again for inviting me, Dr. Tariq. It's such a pleasure and it's such an honor. Thank you.
So thank you so much, President Shahabuddin, for your valued remarks, and we are really thrilled to have you here. You know, this Educational Research Day has become now a mini conference sort of a thing. Maybe for the next year or thereafter, I think we need to have this program as a full conference in health profession education. I think there is a need for a full conference. It has become a mini conference.
Here's my challenge to you. Why don't next year you convert this to a full conference?
That's what I'm saying. That's what I'm saying. Next year, I think it should be a full conference because it has become a mini conference. But I think next year we need to have a full-fledged health profession education conference. Another thing is that as we are receiving number of abstract in health profession education, and a number of research in health profession is increasing in our university as well. So I think we need to work on bringing out health profession education journal as well. So I think that we may be thinking about that thing as well. So I think with that, I think I would like to invite our keynote speaker for today, and who is Dr. Muhammad Al-Iraqi. And Dr. Muhammad Al-Iraqi will be talking about future of assessment in health profession education. And he is currently working as the Director for Development and Academic Initiatives at the Vice President Office for the Academic Affairs at Imam Abdul Rahman bin Faisal University, Saudi Arabia. In addition, Dr. Iraqi is also visiting professor at master's program in Rifa University, Islamabad, and Lahore University of Lahore, Pakistan. Dr. Iraqi is a member of the planning and assessment team from Maastricht University, Netherlands, in 4 modules of the joint master's program in health professional education between Swiss Canal University and the Maastricht University, Netherlands. So he's one of the person involved there, and recently recruited as a tutor at the master's program of medical education at Dundee University as well. So Dr. Iraqi, he will be talking about future of health. He will be connecting online and already there, Dr. Iraqi, and welcome, Dr. Iraqi, for joining. And it's over to you.
Assalamu alaikum, sir. Thank you very much, Dr. Tariq, for the very interesting, nice introduction. And I would like to thank Dr. Sonia for inviting me to the 5th research day. This could be the first time I'm officially speaking at Aga Khan University, but I have so many friends, colleagues, students in all over Pakistan. It's a privilege to connect with you all again. So my talk will be on the future of assessment in health professions education. How this title is relevant to the research day. I will start with a term that's used by Dr. Tariq in his presentation this morning. He used the term emerging or evolving trends. We in health professions education, we need to be oriented about the emerging trends in assessment, in teaching and learning, in course design, and also the fading trends. So this presentation is about exploring some tacit emerging trends in assessment through a lens on literature in health professions education. And from that, you might find venues for research, future research in assessment and in other areas, but my talk will be mainly on assessment. So there are a couple of trends I've explored in the literature. The first one, and the most striking one, could be the power of subjectivity, or the emerging trend of subjectivity in assessment. And they use this term subjectivity. In the 70s, subjectivity was a bad word, but this article from Academic Medicine by two guru in assessment, Ole Tenkate and Glenn Ridges, they mentioned and they advocated that we need expert opinions in our assessment systems. Objectivity is very helpful. We need an expert opinion, and we need, that's why the wave of entrustment, that you trust somebody to perform particular tasks. So that's the first, I would say, trend or emerging trend in assessment. The subjective assessment with more reliability of expert opinion to grant entrustment decisions or entrustable decisions in students or residents. And since you will rely on experts, you might need more than one expert. You need different lenses to assess performance. So you need to invite many experts to assess from different angles, particularly in high-stake entrustment decisions. And as you see, over the past 3 years on the pandemic, the face-to-face assessments become a challenge. So we might be moving to recorded student performance. That could be the norm. And there could be an area for research in that, on what are the criteria to document performance for entrustment decision or for assessment. Because assessment could be more asynchronous, without the presence of the assessor and students at the same place. So we might need to learn more about this and develop criteria for this. So these are the first, I would say, 3 trends in brief. Moving forwards, or actually backwards, let's review the purpose of assessment or question even why do we do assessment in health professionals education. You're familiar with the purpose of assessment, that assessment of learning, which is mainly for taking decisions, summative assessment to validate learning and award degrees, usually by the end of the course, by the end of the program. And you're also aware about the assessment for learning, which is the formative assessment with feedback to guide learners, or assessment as learning while the students progress through their programs. Is there a third purpose that is emerging in the literature and assessment? Let's see. Now you see there is an implicit new rationale for assessment. Assessment to predict future performance of students and guide student selection. That's why there is an area for research in this domain, predictive validity of some tools and assessment, like personal qualities. Can we decide that certain people, they have certain characteristics to be physicians or to be nurses? Or within a discipline on specialization, some candidates can be psychologists or psychiatrists, while others are better to be surgeons. So there are certain personal qualities that needs to be assessed because they have predictive validity later on. That's why you'll find tools like multiple mini interviews for student selection in health professions training, and there are plenty of literature in this area. So you need to assess students before admission to medical schools and on specialization, which take us to perhaps a third purpose of assessment that we need to consider. There's assessment of learning, assessment for learning, and assessment before learning. I know that this term might be new, but this is like a collective idea on what is already in the literature, that we find we have already tools to assess students before admission or before specialization. So perhaps there is an extra added or amended purpose for assessment that we need to consider. And for that, we need to research the predictive validity. Those who got 90% in these tools, they might, for instance, those who have A+ in graduation, they are expected to be good doctors or good technicians or good dentists. But is it the case? How much the correlation between our grades and the future performance? This is the predictive validity of assessment or assessment before learning. Okay, so far so good. Now, this is like a couple of reflective points. What about the context of assessment? We are familiar about assessment in simulation, as already in the literature, that we assess students in a simulated environment, like in OSCE or whatever. And we are familiar with the workplace-based assessment, and we think this is the top, and this is the final stage of the context, either in simulation, like in a swimming pool, or in the workplace, like in the open sea. Is there a third dimension of the context? This one. Do you consider the workplace of a tertiary care hospital in Karachi is similar to the workplace of a primary health care in Karachi as well, leaving other countries or other contexts? So perhaps we need to consider the place, the venue. And for that, this is an article we have took almost like 2 years in developing this article, Becoming a Doctor in Different Cultures. This is, it has been co-authored by 4 people from 4 different continents. and it's published in Academic Medicine. This article is about a story of a doctor, an Arabian doctor, a Syrian doctor, who moved to the Netherlands, and she's working there as a physician. So she has been trained and assessed in her context as a very good physician. While moving to another context or another culture, she encountered challenges and problems with the professional identity. So it's an interesting article. It's like a story, and it tells you how people needs to be acquainted to a new context. And it's not only about the workplace, but it depends which workplace. The same theme in the literature, you'll find it in professionalism, for instance, because it's very context specific. And that's part of my PhD in Maastricht. It's about developing a model of professionalism in the Arabian context, which is the 4 gates model. Here, for the first time, we acknowledged self-accountability as taqwa and self-motivation as ihtisab, which is expecting reward from Allah, from God. So we found there is a relevant 4th gate, which is dealing with God. The others are already there, dealing with self, dealing with task, dealing with others. But dealing with God and the role of belief, of faith in our performance, in our teaching and learning, this needs to be acknowledged. So again, assessment needs to acknowledge the context and the culture and the venue and the location. It's not only the workplace. The same line, you'll find also articles on professionalism from China, where Pan and his colleagues, they found relevance to the Confucius disciplines and the guidance in professionalism. And in Japan, also they found it with Bushido concepts in Japan, in like samurai culture. So this takes us to something that we need to make orientation to fellows and students and graduates when they move to another context or another culture, and they need to reassess. Yes, reassessed again, because they have been assessed in their context, but they need to be assessed in the new a new location or new concept culture. This is an interesting letter in medical teacher. You know the idiom of when in Rome, how to continue when in Rome? Do as the Romans, right? But we reversed the idiom. We said that when in Rome, Romans should help visitors. So when in Pakistan, for instance, Pakistani people, they should help visitors on how to be acquainted to the expectations, societal expectations, and the regulations, so many things related to the context and the culture. So back to the trend here, that there is an emerging trend of the context of assessment. It's not only about simulation or workplace, but the broader context about where are we assessing our students? Are we training them to be professionals in primary care units or in tertiary care? How they deal with less resources, how they can manage to work in different contexts. So this is a new dimension, perhaps, for research in assessment on how we can prepare our graduates for that. Now, another question. Assessing what? That was assessing where. Now, assessing what? What are the constructs of assessment that we see in the literature? Mostly, you'll find that we are assessing observable, explicit behaviors, things that we can see, which is reasonable. I mean, I need to give a mark and make a decision on the performance of students of particular skills. But is it all about skills and performance? Or we need to assess something more difficult and more implicit? Yes, we need to research this. Assessing, I know this is like a dangerous water, but we need the assessment of today, where assessors used to measure observable behaviors and demonstrated skills, things that they can see and they can measure. But as you know, that there are more important things that needs to be measured and assessed. And I give it a couple of examples now. So we need to attempt to measure implicit attitudes and attributes. Like what? And then I'll tell you why is that? Why do we need that? First, like what? What are the constructs that we are missing, that we are not assessing? Empathy. Over the past 10 years or more, you'll find so many literature in assessment of empathy using scales, and it's self-administered or using 360 degrees from different, particularly from patients and family. So empathy is one of the constructs that is implicit. What else? Emotional intelligence. Another important construct, and you'll find so many articles over the past maybe 15 years or more, and how it's relevant to performance. And of course, professionalism, the assessment of professionalism. There were recommendations from Ottawa Conference, and it has been reviewed and updated recently. And I was honored to be one of the working group for that assessment of professionalism. And even going into more deep about assessment of professional identity. For that, there were some attempts to amend Miller's pyramid to assess the identity, like the is part of students. But then we, a friend of mine, Hisham, and I, we were thinking to think outside the pyramid, and we proposed a fresh look at Miller's pyramid, which is assessment at the is, and we added another level, do, not does. How is that? This is the original Miller's pyramid that has been there as an iconic framework for assessment for the past 30 years or more. As you are aware about, this is like starting with knows how, shows how in simulation, and does in a workplace. Now, you may expect that we need to add to does on where exactly, which workplace. We propose assessment of bits, which includes the knows, which assessment of abilities, include 1 and 2, and assessment of the shows, which is number 3, and of course the same one, assessment of the does, individual performance of students or graduates. Are we missing something? Yes, we're missing 2 things. First, we are assessing candidates as individuals, but we need to assess candidates as, first we need to assess the implicit attributes of individual candidates, assessment at the is level, which is very close to the candidates. And we also need to assess learners as in teams, not as individuals. That's why it's not, does is not enough. We need to add another dimension, which is assessment of the do together. Here, we will accommodate all tools for assessment of the team, either in simulation or in workplace. The code blue, for instance, is assessed here. The all group tasks, interprofessional education will be assessed in this domain or in this dimension, assessment of the do together. So the assessment orbits present more ideas or more venues for tools and for research. The last point or the last trend, when do we assess students? Currently, the model of assessment worldwide mostly is like assessment is scheduled at fixed time, usually at the end of the rotation, of the course, or the year, or the program. But perhaps we need to time here is fixed. But assessment in the future, where learners will be assessed whenever they feel ready or they are competent enough to pass preset criteria. So some students will finish medical schools maybe in 4 years, 3 years, while others, they will need 7 years. And the same for specializations. This is even more clear in specializations, in rotations and so on. So here, the time factor may not be the fixed, but could be the variable. So this is just a couple of reflective points that you may consider while thinking about research and assessment, because this is about assessment of future. Let's summarize them all together. The first one is the assessment judgment or the subjective opinion, expert opinion, multiple experts. This one, recorded, and assessment before learning, before entry of the medical school or before specialization. Assessment of implicit. I know this is difficult, but there are evidence that most of these implicit will contribute to future performance. So it's better to do it early on. Not enough, but we need to assess the location or the culture. So this is the third dimension of the context. And assessment of teams, not only as individuals. Finally, the time. The time is variable. While the competence is fixed, people will pass at different time intervals. So these are like 8 selected points or trends from the literature on the future of assessment. And thank you very much for your attention, and hopefully to see you in future events in Al Khan. Thank you.
Thank you, President Shahabuddin, Dean Adil, and all the esteemed faculty. Shahid Shafi is there, and all the faculty chairs and the participants who are there online for this inaugural session. And we'll be meeting in 10 minutes time. Thank you. Thank you.
Yes, Imran, now you can start. On gun.
Right. So thank you very much for convening back into the auditorium, um, and thank you for joining us online. So I will begin with the introduction of the judges. Today we have 3 judges for our 3 sessions. Dr. Naveed Yusuf, he's an assistant professor and associate director, examination board at Aga Khan University. We have Dr. Ambreen Usmani, who is Dean, Health Sciences and Principal of Medical and Dental College at Bahria University, Karachi. We have Dr. Zareen Siddiqui, who is a psychiatrist and a medical education, currently reading the MD program at Wynn University, Australia. And a very warm welcome to you. Thank you very much for joining us. And thank you, Dr. Zareen. I see you've joined online, and it's really good to see you. So with this, now I would like my team member, Dr. Javeria, to please come and start moderating the very first session. Over to you, Javeria.
Thank you, Dr. Sonia. So, Assalamu alaikum, everyone. We'll now begin with our first session of the oral presentation. Just to mention that there will be 4 presentations in this session, and each one will be of 8 minutes duration. The question and answers for the presentation will be held at the end of the session. You all are requested to kindly send your questions on the link that has been provided to you in the emails with the name of the presenter to whom the questions is addressed. So I would now like to invite our first presenter, Ms. Mariha Zaki from the Aga Khan University, Karachi. The title of her presentation is Impact and Efficacy of Introducing Multi-Tiered Online Educational Interventions for Healthcare Workers During the COVID-19 Era. So Ms. Mariha, please.
Thank you, Dr. Javeria. Assalamu alaikum. Good afternoon. My name is Mariha Zaki, and today I will be presenting you our study entitled Impact and Efficacy of Introducing Multi-Tiered Online Educational Interventions for Healthcare Workers During the COVID-19 Era. There is an apparent deficit of trained critical care workers globally, particularly in low and middle income countries. And in a recent study conducted in Pakistan, it was found that only 12.1% of ICUs in our medical institutions are supervised by trained intensivists. This lack of human resources became even more concerning with the advent of the COVID-19 pandemic in early 2020. Educational interventions are an alluring approach to combat this lack of human resources. However, time constraints, lack of training opportunities, and the recent emergence of the COVID-19 pandemic have hindered in-person critical care education. In the hope of mitigating viral transmission and promoting student-led education, many institutions have leveraged advanced technologies to deliver education. This paradigm shift has promoted pedagogical novelties such as e-learning to facilitate the global transition of the traditional methods of teaching to an entirely online approach. E-learning is now a widely accepted mode of educational delivery with numerous critical care courses available online. However, previous courses have not provided a broad critical care curriculum, nor had they covered the specific intricacies of managing COVID-19 patients. In light of this, the Al Khan University deployed 6 online courses aimed at increasing not only the knowledge, but also the confidence of healthcare providers for management of COVID-19 patients. The objective of our study was to provide rapid critical care education in response to the COVID-19 pandemic. 6 courses were delivered in a bimodal format as synchronous and asynchronous online lectures and videos, followed by case-based discussions. These 6 courses were starting with COVID in April 2020 and continuing on with the critical care course for management of COVID-19, prone positioning for patients with COVID-19, caring for COVID-19 patients in intensive care areas, which was a specific course for paramedics, COVID 2.0, an update on the COVID pandemic, and most recently, the critical care management for COVID-19 webinar, which was conducted in August this year. So we had 3 assessment techniques for our courses. First of all, we had pre-tests and post-tests to assess the baseline knowledge and subsequent improvement in knowledge. Secondly, we disseminated immediate feedback forms after the course to evaluate the perceptions of the participants. And lastly, we reapproached the participants and assessed their feedback 30 days after their course completion to understand the clinical impact of our courses. So moving on to the outcome of our study, we had 10,425 participants from 154 cities globally who registered for the courses. This includes participants from 79 cities in Pakistan. The largest segment of our participants were students, interns, and medical officers. In terms of knowledge acquisition, the highest improvement in knowledge was reported by participants of the prone positioning course, with a median 10% increase from pre-test baseline knowledge to their post-test knowledge. These results were obtained from the 30-day feedback forms. So as you can see, 83% of the participants used the knowledge gained in their clinical practice. And a prerequisite for management of critically ill patients is not only having access to the correct information and knowledge, but also possessing the confidence to be able to manage such patients. The COVID-19 era has been a challenge to everyone, but particularly impacted the mental health of the medical community, and especially healthcare workers working in the ICU. Therefore, assessing the confidence of healthcare workers was an important aspect of this study, which you can see from the top bar graph over there. 90% of our participants felt more confident in managing COVID-19 patients after they participated in the courses. We also established the efficacy of the courses by asking participants if they would recommend these courses to their peers. So 94% of the participants agreed that they would recommend the courses to their peers, which further emphasizes the value of having such interventions in critical care medicine. Another important point to note here is that we are also providing access to these courses on LMS. So anyone who wants to participate in these courses still has the opportunity to do so. So if you've heard about them from your peers, please contact me and I will allow you access to the courses and you can still continue with these. Finally, we assess the clinical impact of the courses by assessing how many COVID-19 patients were managed by our participants after attending the online training. It was revealed that over 19,000 COVID-19 patients were managed by the participants of our online courses. These online educational interventions were not only able to improve the confidence and knowledge of the specific healthcare workers, but also increase the capacity of healthcare workers who were able to manage the COVID-19 patients during the pandemic, which means that we were able to have a ground level impact after these online courses. Our findings prove that rapidly deployed online training can be used to build the capacity of trained critical care workers in Pakistan and globally. Just a couple of suggestions for future researchers. So future researchers should focus on participant attrition. As you may well know, in online education, there is a high percentage of attrition. A lot of the participants withdraw from the courses due to varying reasons such as time constraints and personal reasons as well. But we should consider techniques to minimize this and design courses in multiple languages to increase the global reach of the critical care e-learning. Thank you for listening. And if you have any queries, please, as Dr. Javeria said, please reach out via the link provided, or you can reach out to me via this email address here. Thank you, everyone. Thank you to our judges.
Thank you, Mariha. As mentioned again, you are requested to kindly email the questions on the link provided with the name of the presenter to whom the question is addressed. I would like to invite our next presenter who is with us online, Dr. Shazia Fakhr Durrani from Bahrain University Medical and Dental College, who would give her presentation on experiences of undergraduate medical students regarding virtual clinical rotations during COVID-19 in Karachi. So do we have Dr. Shazia? Okay, so over to you, Dr. Shazia.
Yes, Dr. Shazia is connected. We are writing her to turn on her video and mic.
Assalamu alaikum. Can you see me? Is my screen visible?
Yes, Dr. Sir. Please put it on slideshow.
Yes. Is that okay?
Yes.
Thank you. May I start now?
Yes, Dr. Shazia, please start.
Okay. Assalamu alaikum. My name is Dr. Shazia Fakhr Durrani, and this is my article on experiences of undergraduate medical students regarding virtual clinical rotation during the COVID-19 pandemic in Karachi. And my co-authors are Dr. Mara Hamid, Pooja, Aisha, and Fatma Fakhr. So we were interested in knowing the lived experiences of undergraduate students during this COVID pandemic. And these experiences let us know whether learning was actually taking place during the virtual clinical rotations, especially in our country, in an underdeveloped country. And I also wanted to know what steps we should take to ensure that this clinical teaching is actually taking place and learning is actually happening. So as we all know, the post-COVID era, it required new strategies. Everything was shifting to online, there was lockdown and education was being badly affected and we had to do something immediately. So low socioeconomic countries, we cannot afford expensive gadgets like high fidelity simulations, holographic cameras. Most of our medical institutes could not and still cannot afford all these high fidelity techniques and other latest technologies for their students. So it was a concern to continue virtual medical education in our country in the best way possible. The objective of this research was to explore the lived experiences and feelings of clinical year undergraduate MBBS students regarding virtual clinical rotation. So we interviewed about in-depth interviews of 7 students taken from clinical year undergraduate MBBS. The setting was in private and medical universities in Karachi. Duration was about 6 months. from September 2020 till February 2021. The feelings and views of them were recorded through video clips and conference calls because it was all happening online anyway. But still, we could take two live focus group discussions. They were conducted and recorded. After transcription, codes and themes were made and data interpreted and recorded. So the main outcomes we were expecting were the effective clinical teaching and learning takes place or not virtually in an undeveloped country, undergraduate medical schools. And what are the possible steps to ensure this? In total, in-depth structured interviews were taken and 2 online synchronous focus group discussions. The results included that 4 to 5 participants included in each group of the focus group discussions. So there were a total of 17 respondents, and more than half, 60% of the participants were females. During the analysis, sub-themes were made, codes were given, and they were identified and classified under 4 major themes. The first one was they did not get the true feel of clinics when they were having online virtual clinical rotations. The second theme was history taking of simulated patients was a good idea and they thought that it helped them. Third theme was no hands-on learning because procedures and everything, it required hands-on learning and there was 0 hands-on learning during online classes. And the fourth theme was weak internet. All the students complained that weak internet was causing disturbance in the video and disturbance in their learning. So other things which we gathered as a result were the online clinics were not as effective, the skills and examinations not learned at all, interaction was less due to internet connection failure, and most students preferred face-to-face for clinical rotations due to lack of technical resources. So the themes 1, 2, 3, 4, I would like to quote some students according to the themes. Theme 1, in which they said one student quoted that home environment was a distraction because we would be dressed in home clothes, pajamas, and we would eat snacks and as we like. And since no one was really looking at us, so we would be tempted to check other tabs in the computer and also be distracted by voices at home and bell ringing, etc. So that was a big distraction during those times. And second theme, I quote, we were given access to a website, Cyber Patient, where we would ask the patient history on our own and also decide what examination was to be done and made differentials on our own. This was a very good experience and lots of learning took place, but the whole process was unsupervised, which made us less motivated to continue. And the students said that we did this once or twice and then we just gave up. The third theme I quote, just because I know the steps does not mean I know how to do it. I think this was the most significant thing during my research, which I noticed that clinical rotations cannot make a student learn how to perform a procedure because they know the steps, they know the contraindications, they know how it's to be done. But since they have not done it, that means they don't know how to do it because until it's actually done and performed under supervision, they will not learn. And the fourth theme, which was also very important, was the internet issue. And I quote, whenever we started getting interested in online video or wanted to interact or ask a question, the internet got disconnected and we lost all motivation for that class. This was really all those things which all the students gathered and their true feelings during the clinical rotations which took place. And in conclusion, I would say that online clinical rotations cannot replace the actual campus and clinical face-to-face teaching in low socioeconomic countries. By saying that, we can still make improvements in the clinical rotations by whatever happened, by improving the internet issues and also maybe increase the interaction. The question answer sessions can be improved, small group sessions, and this can in fact not replace the actual campus field, but still we can do whatever we can for our students. Thank you. How do I end steps?
Thank you, Dr. Shazia, for an informative presentation. Again, to remind the audiences, to kindly email their questions, which are addressed to the presenters, and we'll cater them towards the end of the session. I would like to invite our next presenter, Dr. Qamar Riaz from the Aga Khan University, for her presentation on evaluating clinical learning environment for postgraduate trainees at a tertiary care center. So Dr. Qamar, please.
Okay, Assalamu alaikum. So I'm presenting my study evaluating clinical learning environment for postgraduate trainees at Tertiary Care Center. I do not have any financial or personal conflicts of interest. Okay, the clinical learning environment is an important component of the residency curriculum. It is the overlapping space between the educational context, which comprises of the curricula, the syllabi, the learning goals and outcomes, different teaching learning strategies and assessment practices, and the work environment, which is actually the clinical context where the trainees learn and participate in patient care. For residents, the majority of learning takes place in this avenue. There are three essential elements of any clinical learning environment. First is the trainees' assimilation as responsible members of the healthcare teams. The responsibility here refers to the autonomy in performing activities at an appropriate level of competence with due accountability. Second is the faculty supervision and role modeling, which means assessments, feedback provision, mentoring, and coaching to the trainees to help them achieve competencies. The third and the last component is the conditions at work that facilitate learning. It comprises of service education balance, relationships, and social interactions that enable learning, and finally, a feeling of the security and well-being on the part of the trainees. So in a nutshell, the clinical learning environment is the sum of the internal and external circumstances and influences that affect a trainee's learning and working. Comprises of physical and virtual spaces, organizational systems, structures, policies, cultures that are defined by the relationships between faculty, staff, patients, and trainees, and also their shared values, attitudes, and norms, and learners' interaction with this environment and opportunities within. All of these surround and shape learners' experiences, perceptions, and learning. So no matter how sophisticated technologies you have, how much beautifully you have defined the competencies, it is a learning environment that actually helps a trainee develop into a lifelong learner and prepares him or her for practice independently, and eventually guides the educational innovations and design. Now, the only or the most common method of measuring a clinical learning environment is by measuring resident perceptions of their clinical learning environment, which serves as the quality indicator of workplace learning. Residency programs that are perceived of having optimal learning environment also considered as supportive of their trainees to be motivating learning and ensuring positive program outcomes. On the other hand, clinical learning environments that are not perceived as conducive to learning impede residents' ability to acquire new knowledge, hinder their growth as professionals, and adversely affects their social life and their ability to contribute in the community. The first residency program at Aga Khan University was started in 1986. Today, there are more than 30 residency programs from different specialties. All of them are accredited by the national accrediting body, that is College of Physicians and Surgeons of Pakistan. Unfortunately, there had been small studies limited to single residency programs, but not an overall evaluation of the clinical learning environment for all the postgraduate programs or postgraduate medical education at Aga Khan University. So the aim of the current study was to evaluate the clinical learning environment in the residency programs at AKU as perceived by the trainees and identify the strengths and weaknesses. So this was a cross-sectional survey that was conducted in all 34 residency programs at AKU after getting approval from the Ethics Review Committee of the Aga Khan University. A non-probability sampling strategy was used, and all the 500 trainees that were enrolled at the time of the study were included in the study. Residents who had spent less than 3 months' time in any residency program at AKU were excluded because that time was considered insufficient to truly understand the learning environment. The postgraduate hospital education environment measure, that is FEEM, was administered electronically via Google Forms to all the trainees. FEEM is a 40 items self-report inventory that measures learning environment during the hospital-based training in the 3 main domains of autonomy, teaching, and social support that corresponds to the 3 essential components of the clinical learning environment. Prior to administering, it was piloted on 5 fellows to ensure clarity, comprehension, and relevance to the context. A total of 347 trainees responded, giving a response rate of 69.4%, of which 119 were males and the rest were females. The mean FEEM score was 107 out of a total of 160. The reliability was 0.95. There was no significant difference found in the mean scores on the basis of gender. This table here shows the scores, the mean scores of the overall instrument, as well as in the 3 domains. So the overall mean score was 107, corresponding to the more positive than negative perception, but room for improvement. In the domain of autonomy, the residents perceived it to be more positive perception of their job. The domain of teaching was scored most, was the highest among all the domains and indicated moving in the right direction, while that of the social support, residents perceived it as having more pros than cons. There was significant difference in the scores on the basis of the residency program. So all the bold in black are the areas where their residents scored more or higher, while the red ones are the ones where the scores were less. Surgery was one discipline where the surgical programs scored all the domains towards the lower side, while radiology scored all the domains and the overall on the higher side of the learning environment. There was also significant difference on the basis of the year of the training of the residency program. So the junior ones considered or perceived the learning environment as more positive as compared to the final year trainees who perceived as poor or needing improvement in the clinical learning environment. So to conclude, the quality of the clinical learning environment that provides context for training also predicts the quality of care provided, influences trainees' prescribing patterns, their patient management, use of healthcare resources for years after graduation, and thus is an indicator of the quality of its graduates. Therefore, it is important that there are periodic evaluations for the clinical learning environment. The overall FEEM score for the postgraduate programs at AKU was more positive than negative. Remedial measures addressing the areas identified as poor or needing improvement would further improve the quality of the education program and thus environment and thus the program. Thank you.
Thank you, Dr. Qamar. We would now proceed towards the last presentation of this session. And for that, I would like to invite Dr. Aisha Basharat, who is with us online. And she will be presenting teaching and learning activities in critical care, residents' perspective in a developing country. So over to you, Dr. Aisha.
Assalamu alaikum, everybody. I hope I'm clear and audible.
Yes, Dr. Aisha, we can hear you.
Thank you very much for giving me this opportunity. I'm going to share. I hope my screen is also visible.
Your screen is visible, Dr. Aisha.
Okay, thank you.
Could you please turn it into the slideshow format?
Yes, I'm doing that. Just give me a second. I'm sorry.
Dr. Aisha, can you please turn on your video as well?
Yeah, sure. Just give me a second. Let me fix it to the slideshow. Is that fine?
Right, thank you.
So I'm basically going to talk about teaching and learning activities in critical care residents' perspective in a developing country. It was a research done by Dr. Aisha Aleem Qureshi, Lubna Miraj, Wajid Munir, Ghulam Murtaza, and Mubin Iqbal with me in this project that we did. So I'll taking you through the introduction, background, what was the rationale of the study, what was our main objective, methodology, finally results and conclusion. So talking about critical care, as we have been going through COVID-19, and we saw that critical care units are few in Pakistan, which were actually training critical care residents, although we have now this critical care residency, but the critical care physicians, how they are trained, the load on the critical care units increased with this pandemic. AKU has also been guiding many IC units how to manage patients. So a critical care physician is basically a very important person who is dealing with clinical decision making, he's doing physical examination, and at the same time, he's managing patient safety. Although we all who are practicing healthcare professionals are doing all this, and while we are training our residents, we are also giving them this message of patient safety and clinical decision making adequately through our role modeling and different other teaching and learning strategies. But critical care, we believe, is an area where there are unpredictable situations. There can be patients who are with rare diseases, who are at very serious time in their life, who are very critical. And at the same time, how do the critical care physicians manage teaching and learning strategies with their residents? There are challenging learning environments, and how we wanted to see how the residents perceive that their physicians are managing with the teaching learning strategies, how well they get to learn things while being in critical care and in this unpredictable and very challenging learning environment. As I just said, there are few critical care units in Pakistan. The teaching physicians have very big responsibility of training their residents well prepared with all the clinical skills, and at the same time ensuring patient safety, especially in such kind of units. There have been research where they have seen how residents see teaching learning strategies adopted by their physicians in outdoor and internal medicine, but we could not find much data on the teaching learning strategies preferred by residents in critical care. So we thought we should work on this. And medical educationists working with curriculum, working with teaching learning strategies and assessment tools have always been guiding in every institute how to train the residents and which behaviors are more preferred by the residents. But still, we wanted to see what teaching learning strategies are currently adopted by critical care physicians, what behaviors our residents think in Pakistan are more productive for their learning, and what could be modified as a result of this, and what suggestions could be made. So it was to evaluate the teaching behavior of attending physicians and consultants by the learners or residents in critical care settings. It was a cross-sectional study which was done in critical care units of public and private hospitals in Rawalpindi and Islamabad from May 2020 to February 2021. It was a convenient sampling technique, and the total sample size was 173. We actually took 2 articles and another Stanford postgraduate guide, from which we made a 33-item questionnaire tool, which was basically circulated through Google survey to the residents working in critical care and who have spent more than 6 months in that area, so that they could be their opinion could be sought. So there were one was 33 years. We divided those questions in our questionnaire into 3 main domains: the clinical and interpersonal skills, teaching and research skills, and educational training of the residents. And there were further questions in it. So as you can see, the mean Likert scale of education, training, clinical interpersonal skill, and teaching and research skills is here. We measured the responses of the residents on the Google survey. We made it a Likert scale. So 5 was what they preferred the most, and 0 was what they did not like the behavior of the physician as all. This table shows the comparison of the top 5 most important behaviors. As you can see, it was in an article which was published in 2017, which showed that the attending physician enjoys teaching, house staff, and other. But in our multi-center study, as it was done in different public and private sectors, mainly the residents liked the behavior where the consultant showed enthusiasm for the topics which were discussed on ward rounds, and where they shared their professional experiences with the residents. And they liked while the consultant was there to teach the residents and explain clinical reasoning and differential diagnosis in critically ill patient. And then again, the fifth behavior that they liked was that the consultant promoted an interest in research. So these are the main five findings from our study, that our residents thought that these behaviors from the critical care physicians were positively welcomed. So these are the important teaching behaviors as we have seen in research. And critical care, as I just said, was a challenging and unpredictable learning environment, where it was important to see how our residents see their teaching physicians, what strategies should they adopt. So this research can be an important tool in modifying the clinical environment in the units, and can be an important information where the medical educationists can guide the treating physicians to adapt in the critical care, what strategies could be further improved with that. Thank you very much.
Thank you, Dr. Asha, for a very nice presentation here. We now move to our question answer session. In the best interest of time, we would be catering for about 1 to 2 questions per presenter that we have received from the email. So the first question that we have received is addressed to Ms. Mariha. And the question is how development of educational curriculum can be improved in a resource-limited environment. So if we have Ms. Mariha with us. No? Okay. So our next question is for Dr. Shazia. How do you plan to make up for the lack of students' motivation? Dr. Shazia, are you with us? Dr. Shazia?
Yes, I'm here.
Yes, yes. Can you hear me?
Yes, now I can hear you.
Right. So we have a question for you from the audience. And how do you plan to make up for the lack of students' motivation?
Actually, the motivation that has been planned. I also took another survey of how the students would like to improve on all that. So first of all, we decided that there should be a faculty workshop, which is very important, and they should be trained according to the inputs of the students, how they would like small groups and interactive sessions, and more so in order to get more motivated. And secondly, not only interaction, but since now we have done this hybrid activity, so this will help us, and the students can come and get access of the actual clinics and find out if the really learning is taking place, and if the learning is taking place, even if they can go to the skill lab and the simulation centers, then they will realize that passing of the NG and catheterization and such procedures, they have learned them actually, and that will improve their motivation to further do this clinical virtually. In fact, it's not as bad as they think it is. That's what I think.
Okay, thank you, Dr. Shazia. Our next question is for the presentation of Dr. Qamar. And the question is how institutional context and support would relate to the clinical learning environment.
So the institute needs to look at the areas that are specifically identified near requiring improvement, and adapt the structures, the policies that are conducive to learning, and support the trainees in developing the trainees' perception of a positive clinical learning environment.
Right, thank you. Okay, so the next question is for Dr. Aisha. Was there any difference in perception of the residents of the public or and the private sector?
Not exactly. It was, we did collect the demographics and all that was also included in the Google Forms, but we didn't find any significant difference in the perception between public and private sector.
Okay, thank you. So we have a question for Ms. Mariha. How development of educational curriculum can be improved in a resource-limited environment?
Thank you, and sorry for my absence, my brief absence. We're actually conducting another simulation-based training, so I'm involved in that as well. How these educational interventions can be provided to resource-limited settings. Yes, sorry. We're actually providing these e-learning initiatives to resource-limited settings as well. Currently, we're hosting in-person workshops using technology such as simulation and pre-recorded lectures as well. So we're providing those to participants from remote locations such as Gilgit Chitral, remote locations in KPK as well. So what we're doing is we're flying them out from Chitral and other locations across Pakistan, and we're providing them with hands-on simulation-based experiences to build the capacity of critical care workers over there, as well as we've actually seen that there was a recent study regarding the amount of internet consumerism in Pakistan, and that is quite high overall in rural and remote locations. So through that, we are also, sorry, a little bit out of breath. I ran all the way here. We are also promoting these online courses to resource limited settings as well. And we're providing them with, I think we're providing them with laptops too. So if they wish to participate, they are most welcome. Thank you.
Thank you, Mariha. Do we have any questions from the audience? Dr. Zuberi, please.
Assalamu alaikum. Thank you very much for this opportunity. It's actually just a comment based on Dr. Basharat's presentation, that the themes that came out from our own residents did not include any respect for the other members of the healthcare team. And that itself speaks volumes for our training programs. I just want to say that. Thank you.
Thank you, Dr. Zuberi. May I now request one of our honorable judges, Dr. Zareen Siddiqui, to kindly summarize and share the findings of the session. Dr. Zareen is with us online.
Thank you very much. Assalamu alaikum. It's so good to see Dr. Zuberi and all the colleagues that I have worked with. I must just say that I just thoroughly enjoyed. I've been with you since 2 p.m. and I've just enjoyed, and I'm still in that euphoria that you will be running a conference and hopefully will be launching a journal. The 4 presentations that I heard were all excellent. So really just keep it up and bring Pakistan at the top in the educational research. You all have done a great job managing COVID, and I just wish you all the best. Stay safe. Thank you. I would just like to make a comment. Please give us 2 to 3 minutes between 2 presentations so I can score them appropriately. Thanks.
Right. Thank you, Dr. Zareen. We will just wait for 1 or 2 minutes. So meanwhile, we come to the end of our first session here, and we will begin our second session shortly. That will be moderated by Dr. Tabassum Zehra, who is an assistant professor from Department for Educational Development.
I have recently completed my coursework and I'm currently working on my thesis. I have
Thank you so much, Dr. Javeer Rahman. Before we move to the third session, there is a small video of the research experiences for one of our MHPE student. So enjoy and listen to her experiences, and we'll be back in a short while.
I have recently completed my coursework and I'm currently working on my thesis. I have learned about educational research. Coming from a clinical background, that was not my strong point. We underwent modules on qualitative and quantitative research, and our facilitators throughout the program have always encouraged us to think in terms of publication, to think in terms of developing ideas that we can take from point A to point Z and get them published. So thinking in those terms, doing our own research, writing our own papers, writing our own written assignments, and now doing our own qualitative and quantitative research when we're doing our thesis has enriched our lives, because we are not only developing as learners, we are also developing as educators. And for us, working in the clinical field, working with residents, running residency programs, this is not going to help only ourselves, but also our residents, because we are going to encourage them to think in terms of educational endeavors, taking them from the start right up to the point where they get them published. And this will help in development of contextual research in Pakistan, especially in the education, field of medical education, which is still lacking a lot of original publications coming from all corners of the country.
I got to know more about the workplace-based assessment, which actually became the center of my research. And I developed a tool in the workplace-based assessment that became part of my main thesis as well. Today, we are using that tool as part of the clinical assessment of our trainees. Other than the workplace-based assessment, there were so many other aspects of the educational science that I got to understand, and the reasons why we are making a certain paper in a certain way, where to use what type of tool, how to assess students by which method, and the theories of education, and so many other things that really enriched my experience.
So I hope you enjoyed the experiences of our students, which have basically graduated from our program of Master of Health Professions Education. And now we'll begin with our third session for the oral presentations. And the first presenter is Dr. Hola Noreen. She's also one of our MHP student and working in the Rawalpindi Medical University. Her topic of today's presentation is assessment of academic motivation level during COVID-19 pandemic in undergraduate medical students of Rawalpindi Medical University. So Dr. Hola Noreen, are you there with us?
Yes, ma'am, I'm here.
Yeah, can we have your slideshow?
Yes, ma'am, just give me a second, please.
Sure.
So is it clear now?
Yes, and it will be wonderful if you can have your video on.
Yes, ma'am, it's already on. I have turned off my camera.
Yeah, but I guess we are not able to see. Is it okay? Yeah, now it's visible. Okay, thank you. So over to you, Hola.
Bismillahirrahmanirrahim. Thank you very much, Dr. Tabassum. This is Dr. Khala, and I'm student of MHP 16 at Khan University. And today I'm going to present the assessment of academic motivation level during COVID-19 pandemic in undergraduate medical students of Rawalpindi Medical University. As we all know that COVID-19 pandemic is a global health crisis of the time, which has greatest impact on almost all the sectors. The situation has impacted all the systems and institutions, and entire human race is struggling to fight against the invisible, careless, and the deadly virus. The pandemic has disrupted the medical education, resulting in the transition to online activity in response to the need of social isolation to flatten the curve of new cases. Current pandemic has also changed the social norm as a result of isolation and restriction. Indeed, recent international studies showed an alarming increase in the mental health issues in youth. In the light of such evidence, it is reasonable to suspect that academic outcomes, and more precisely, students' achievement motivation, could have been deteriorated in pandemic crisis. In fact, latest evidence has also supported the students tend to exhibit poor motivation towards the learning during pandemic crisis. Unfortunately, during pandemic, students seems to have limited interaction with their peers and teachers, and they have consequently strong reason to believe that their motivation has declined. To our knowledge, empirical evidence has to date have been quite limited concerning this topic. It is therefore difficult to estimate the impact of pandemic on students' motivation level. This study will provide baseline data to develop the target strategies to improve the motivation level of students, especially in our part of world. So objective of my study was to assess the level of the academic motivation using validated and reliable 28-item questionnaire academic motivation scale in undergraduate medical students of Rawalpindi Medical University. This was a cross-sectional study conducted from the year 1 to year 5 for undergraduate medical students of Rawalpindi medical students, and duration of the study was 6 months. Sample size calculated using estimated prevalence of 50% from the international study. Estimated sample size was 384, which was inflated to 401 to cater for dropouts. And we employed convenient sampling technique to gather the data. And all the students who are regularly enrolled from year 1 to year 5 were included in the study, and especially though only those students were included who gave written consent to include in the study. And those students having a psychological or psychiatric problem or depressive illness were excluded from the study. We use data collection instrument. We use academic motivation scale, which is also labeled as AMSC28, which is validated tool. Basically, it is a well-tested psychometric instrument rooted in the self-determination theory by Disier and Ryan in 1985. The AMS28 measures the motivation across 7 subscales of motivation. It contains 28 items which are assessed on 7-point Likert scale. The original version was developed in French, which was later translated into the English, and it has good internal consistency with the mean score of alpha 0.81. These are the depiction of the different subscales. Actually, there are 7 subscales of this questionnaire. So our data analysis was like that. We compare the means. Independent sample t-test was used to measure the difference of mean scores between males and females. And one-way ANOVA was used to assess the difference between mean score across different academic levels. That is from the year 1 to year 5 of undergraduate students. Results were like those who were participated year 1 to year 5 were participating in the study. Total students were 401, and this is their mean age is 23.4, and the breakup of their relative percentages from the each year is shown as 17% from the first year, 19 from the second year, 20 from the third year, 26 from the fourth year, and 15 from the final year. So this table is calculated. This table is showing the difference in the academic scale according to the gender. T-test was employed to assess the difference between the scores in the males and the female. The bold ones are showing the statistical significant difference. And what we observed was that the males have better motivation scores as compared to the females in almost all the subscales, across all the subscales. And this table is showing the difference in the academic scores according to the year wise. This was calculated by applying the ANOVA. And this table, again, the bold ones are showing the statistical significant difference. And what we observe in our study, that the motivation level progressively improved as we move across the from the junior classes to the senior ones. That is, fourth year and final year medical students have better motivation level as compared to first year and second year students. So these are the result. On average, overall scores of intrinsic motivation were higher as compared to intrinsic motivation. Female were less motivated both intrinsically and extrinsically than males. And there is a statistical significant difference were observed across these subscale, which I have already displayed in my previous table. Motivation score also vary across different level of undergraduate study. There was a statistical significant difference across the motivation scales in a different year of the study. Score were higher in the senior classes, that is fourth year and final year, and as compared to the junior ones that are first year and the second year. The highest score was reported for fourth year MBBS and lower for the second year MBBS, both for intrinsic and extrinsic motivation scale. And the statements which score higher among the males are these, and all these statements are depicting that male students have more prosperity towards the external regulation. And these were the statements that were scored high in the female group. And all these statements are pointing towards the low morale of the female during pandemic crisis. So among the several disproportionately affected population, adolescent and the young adults are particularly struggling with the current pandemic circumstances, and our female students had low motivation as compared to males. Similar studies are also, similar results are reported from the results of the later studies, and the reason for the better motivation in male was higher adaptation to new reality of the confinement exerts a positive effect on the physical and the psychological well-being, and also male being able to go outside and preserve communication with the external world and able to maintain the social relationship with the classmates and have a perceived social support. This may explain the high adaptability shown by the participants of our study. Moreover, extrinsic motivation seems to be more deeply rooted than the intrinsic and strongly influenced by the desire to have a good life and remuneration in the future. Motivation score were better in the higher academic years. Possibly reason might be that the fourth year and final year were called for the clinical rotation, which might have contributed towards the better mental health being of these students. So on the basis of our results of our study, recommendations are that for the optimal motivation level, university should adapt the following strategies to support the student, especially during the pandemic crisis. Counseling session for the students to make them cognizant with the various coping strategies can be adapted. Establishment of structured mentoring system, establishment of academic counseling cell, comprehensive institutional services for student support, peer support, PAL, senior, junior, big SIP, parenting, buddy system, social networking, professional identity development training programs, interprofessional communication skills, and hiring of a trained staff for the counseling can improve the current pictures. And these are the references for my study. And thank you very much for the patience listening.
Thank you, Dr. Khola. So, Khola, there's a question for you. What could be the reason of difference in motivation between the males and females in your opinion? Because in one of your slides, you said that your male participants who had more motivation than the females. So do you have any answer to that?
Yes, ma'am. What practically we observe in our setup in our institution was that the male were throughout, even when they were called for their clinical rotation, especially fourth year and final year throughout the pandemic crisis, they were called for their clinical rotations, and they were throughout in touch with their academic activities and their clinical and the practical skills. While even when we call our female students, the parents were reluctant, especially to send their hostelite daughters back to the institution, and female were totally confined, and they were not they gave in written that they are not willing to come to the university during the pandemic crisis. And this might be the reason that the psychological impact of the crisis, because they were more confined and they were more into the restricted environment, that might have contributed in that females have more low motivation levels as compared to the males. This is particularly pertaining to our setup.
Right. Thank you, Khola. So have another area of research to do now.
Thank you, ma'am.
Now with this, we have our next presenter, Ali Ahil Noorali. Ali Ahil is one of the graduate of Aga Khan University Medical College. And there are a number of co-authors with Ali Ahil. So the presentation that he's going to make is on a nationwide virtual research education program for 3,800 medical students in Pakistan, methodology, outreach, and outcomes. So Ahil, are you there with us? Yeah, thank you.
Thank you so much for the kind introduction. Assalamu alaikum and good evening to everyone here. It is a real honor and privilege to present in front of many of my teachers and also now co-investigators. So the topic that I'm going to present on is a nationwide virtual research education program. And this was conducted for 3,800 medical students in Pakistan. What I'll be focusing on today is how we went about this intervention, what our outreach was, and specifically which areas we reached out to, and the first year of outcomes that we had. We also have a poster presentation that talks about the second tier of outcomes, so more on that later. Right, so when we started conversations around doing this intervention, we explored literature and found out that over the last 3 decades, we have seen a consistent decrease in the number of physician scientists. And this is strongly supported by US data, where we have a plummet from 4.7% in the 1980s, and this is the decade, to 1.5% in the 2010s. We don't have evidence for Pakistan, how many physician scientists we have and what the trend has been, but we know that there are only a handful of physician scientists in the entire country. So to address this specific challenge and also to reverse this trend, we thought that it was very important to develop and cultivate this research interest right at the start of a physician's career when they are at the medical student level. And we also believe that if this deficit is left unattended and if nothing is done about it, this will only increase the divide and disparity in science and medicine both. So one more thing that we found out, and this was also corroborated in our results, that many universities in Pakistan don't have a research program within their medical curriculum. We at AQ, alhamdulillah, have been blessed to have one, but we just wanted to use this opportunity to extend this to our colleagues all across Pakistan. So these were our objectives and outcomes. In this presentation, I'll be talking about how we underwent the program itself, which was the virtual research workshop course. And you can see that this is in the early days of the pandemic, June 2020. So we learned a lot with our colleagues across Pakistan. These were 4 sequential online interactive workshops, and each had specific learning outcomes. These were designed, curated, and scrutinized by experts in research methodology, and I'll be adding to that in a bit. Our outcomes that we were looking at were threefold. First was outreach. So we wanted to know how many people we reached out to all over Pakistan. Step 1. Step 2 was to find out what the baseline knowledge was using a pretest, and then what improvement resulted from our intervention, and then see the pretest to post-test conversion. These questions were about knowledge as well as application, because we thought that applying the knowledge was also as important as having that baseline knowledge. And lastly, very important to know the subjective outcomes. So what the participants felt themselves about how they had learned through this course. And this was done using a standard Likert scale. So the methodology, this is an unconventional methodology. We also have all the study design and all those things as well. But what I wanted to focus on in this presentation was how we went about the intervention. So the first part was a multi-tiered planning cycle where we started with a Gantt chart. We wanted to follow everything according to deadlines, and we set out our target goals. We then identified subject experts across the university. We asked them to help us with the course development and then to refine it. The assessment was also drafted concurrent to this, and we used both peer review as well as expert review for our questions. Our questions were then refined and amended, And then there was a validation done using a pilot run as well. And then obviously, as with any intervention, we needed a strong logistical team, marketing and communication team as well. Now, this was the planning cycle. We had a plan. We wanted to start this all across Pakistan, but how would we go about it? So we used a triphasic enrollment strategy with medical students. As I'm sure everyone knows here, social media is the most popular. So we had 3 channels: Facebook, Instagram, and Twitter, which spread the message to our students in Pakistan. We had our university administration through the registrar's office also help us with this. And finally, we have our ambassador network through the Student Research Forum, which helped reach out to our colleagues at other institutions. We wanted to ensure that the responses that people were giving had informed consent first, and also they were de-identified. So every single participant had a de-identified code, and we used that to analyze, so no one knew who got what score. As with any intervention, we wanted to start with an orientation. We realized that a lot of these people were from very different and culturally diverse areas of Pakistan. So to bring them onto one page before we started our intervention was very important, and that's where we had our orientation program. And then finally, we used our pre-test and post-test as explained. So what really was our educational content? And this was divided into 5 big themes. There is not, statistics is not included in this, but I'll be talking about them in the limitations as well. So we wanted to teach students about the research process. So how to come up with a hypothesis, how to come up with a standardized research question, and then the steps of a research methodology. We wanted them to be ethical in their approach. So RCR stands for Responsible Conduct of Research. So we had concepts about that. We wanted people to know about the 3 important misconducts. So fabrication, falsification, and plagiarism. And also guidelines for communication, how to communicate with patients and how to deal with that communication confidentially. We also taught them how to do a literature search. So the popular ones that we picked up were PubMed and Google Scholar, how to use Boolean operators and truncation for advanced literature search, as well as mesh terms, DOI, and impact factors. Then we wanted them to know, okay, fine, they've done a literature search, now how to write their manuscript. So the abstract part of manuscript, the study objectives, which the format that we used were the SMART objectives, and the ICJME criteria for authorship. And this we felt was also important, tying in with our ethical principles. And lastly, referencing. So as with any manuscript, very important to know how to reference a manuscript. So we used EndNote and Mendeley to teach students how to use those, as well as different referencing styles. So Vancouver, AMA, etc. So how did we then assess people? So that was all the outcomes that those were all the learning objectives, but then how did we assess our students and know whether they actually got the instruction that we wanted them to get? So the MCQ, the BCQs were single choice, best choice questions, and they had 2 types of questions. So there was a scenario-based question, and then there was a very clear knowledge-based assessment. And every test of the 4 series had a mix of these. For subjective, like I mentioned, we had a 5-point Likert scale, and this was standardized, and every participant evaluated their own perception, both before they started the intervention and then afterward as well. I have a few examples here down below for the audience to view. So this is a question from the first workshop that we had, where we talked about falsification, plagiarism, and fabrication. And this question used the scenario-based question style, where students were expected to understand the question and apply their knowledge. And on the other side, you can see the standard Likert scale. So that's what people used to see whether they had a baseline knowledge before the workshop, and then after the workshop, this was their own self-perception. For pilot testing, we used 4 medical students. Obviously, when we pilot tested, we did not expect 3,800 medical students. It was never meant to become that large. When we got the outreach, then we found out. So that's why we had 4 medical students who attempted this test prior to starting the series. And then we got expert input from a DED faculty member, the 5 session presenters, as well as an independent reviewer. So now, talking about did we deliver our results? We had registrations from 41 cities, 123 universities, and 3,800 plus participants. We had more female students. we had more students from private medical colleges, and about approximately 70% of the students did not have any prior publication or publishing experience before they started the series. An important figure here is that we geo-mapped the participant distribution across cities in Pakistan. And I just want everyone to remember this, because I want to come back to this in the limitations about how there are so many areas in Pakistan where we did not get a single participant and how we plan to counter that now. So objective assessment. We had 4 tests and each had between 14 to 20 questions. And for every single test, alhamdulillah, we were able to successfully deliver our concepts. We had a positive improvement in every single one. And I know this sounds very strong, but we had a very statistically significant p-value for each of these. We checked it thrice, but it still came out to be statistically significant. And our overall improvement was from roughly 40% to roughly 60%, which was a 50% improvement from the baseline. We also found that private institutions had a higher improvement than public institutions, and this is higher improvement. And female students had a higher improvement than male medical students, and there are reasons for this as well. We also made some box and whisker plots for the audience to view. So this is just reflecting the same findings in the tabular form, but showing how each post-test ended with a better outcome than the pre-test. Finally, with subjective assessment, we had red to green shift, where we had the Likert scale. So dark red is strongly disagree. Red is disagree. 3, which is neutral, is in the middle. The color is not reflecting that well here. Agree was 4, and then strongly agree was 5. And we found that participants themselves felt that literature search and abstract and manuscript writing were the things that they learned the most, specifically mesh terms and Boolean operators. Every single item on this list, as you can see, showed a positive trend. And the least positive trend was shown in the research question and hypothesis and the methodological approach to research. These were our learnings and limitations. So in Pakistan, we had rain at that time, as well as a lot of electricity outages and internet issues. We understood this. We knew about this before we started the intervention. So we sat down with every program faculty and we made a handout for students who were unable to attend live. However, these handouts were only distributed after the post-test was done, just to ensure that the results we were getting were also reliable. We wanted brisk communication because obviously troubleshooting issues can happen. We had 20 organizers working on all the time, and we had a total of 16 WhatsApp groups, each with a high number of participants. Statistics were intentionally not included in the program, the first rendition of the program, because we thought it was our first time doing this, so we didn't know how the impact would be. And statistics is very hard to deliver online, so we thought that for this year we should not have done that. And we absolutely needed more reach in Balochistan, Kashmir, and Khyber Pakhtunkhwa. And our approach this year is trying to target that. This is obviously the very first step that we had in a curated virtual learning platform. We also achieved a connection between the entire undergraduate medical community in Pakistan, which we thought was very novel as well. We know that the turnout shows that there is a very clear need for research education programs. If everyone knew everything, they wouldn't have registered. So this high number shows that there was a great need. And we want to establish that this newfound momentum should not erode with time. This should not be a one-off series. We want to do this every year. And our ultimate goal is to make undergraduate research accessible, actionable, and sustainable. So this is just a news clip. So this story was covered in Dawn, as well as in multiple other journals. This is a poster where our dean talked about how it's important to do 3 things from this workshop: implement what they learned, share with others who were unable to attend, and then change the status quo at their own institutions. Lastly, like I said, talked about sustainability. So we want to do this again, and we are doing this again. So this year, October, we have part 2 of this series coming up. And those are just the posters for our audience viewing online. If you are a student of any healthcare, it was medical students for the first round, but if you're a healthcare student of any specialty, you're welcome to attend, and we look forward to your registration. Thank you so much.
Thank you. Ahil, we have a question for you now. This was a very wonderful presentation, and I believe it has opened a new thought for medical students, right? And it was very nice to see the medical students of AKU reaching out to other medical institutions and catering to the needs of the research. So the question is, how did your results differ according to the geographical area? Because you did mention at some areas in Pakistan, they were not that kind of a response. So did your results get affected?
Right. So thank you for an excellent question. Our results, so we did a geographical analysis of the results as well. So we wanted to find out whether people in Punjab or Sindh did better than other provinces, or if other provinces did better than Punjab or Sindh. Unfortunately, these results not projected here were non-significant. And the reason why this happened was because we had a very less sample from Balochistan, KPK, and Kashmir. So where we had only 2 or 3 participants, it was very difficult to get a significant result and confidently state that, you know, these areas did better across the country and these areas did not do as well. And that is why it is not in this presentation, but we did do that analysis. And we found, if I remember correctly, Punjab and Sindh were very similar. And then there was not enough data from the other provinces for us to compare the other provinces.
Okay, so I would also like to know if you get out to reach to other institutions and approach and see whether they were offering any kind of research teaching to the students, because at AKU we know that we have our students go through certain projects and they have an understanding of the research, basic research methodologies. Were there any institutions that you reach out, they had any kind of, you know, such kind of instruction to the medical students?
Right. Once again, thanks for another excellent question. So we had this thought. We wanted to get a scope of what was happening in Pakistan. Obviously, our questions weren't able to determine that specific point. So we did focus group discussions. We did 11 focus group discussions from students all across Pakistan, participants of this series. The results of that intervention because it was such a big intervention, we divided our abstracts here into this category and then the other category. We did qualitative analysis using NVivo, and inshallah, the audience will be able to hear about the qualitative results very soon. So that's one of the poster presentations as well. But we did find out what the scope was. And I don't want to take away from the other presenters. So I want them to get a chance to talk about that.
Thank you so much. Thank you for this wonderful presentation.
Thank you so much.
Yeah, so we have a comment, from Dr. Rukhsana Zubairi.
Rukhsana Zubairi, thank you very much. It was a wonderful presentation. I think the whole project was fantastic. Just a suggestion. When you do a pre-test, post-test, for the post-test, put in the pre-test scores as a covariate. That, if you want to publish it, it'll carry more okay?
Thank you so much. That's a great suggestion. Thank you. Hafiz.
Right, thank you so much. Now we move on to our next presentation. So the next presenter is from School of Nursing, Aga Khan University, School of Nursing and Midwifery. Leila Akbar Qasim, she's going to present on the stakeholders' experiences of virtual instructions in post-RN baccalaureate nursing program during COVID-19 pandemic. Ms. Qasim, over to you.
Thank you so much, Dr. Tabassum. Bismillahirrahmanirrahim. Distinguished leaders, guests, and the entire audience. Good evening and Assalamu alaikum. This is Leila Akbar Qasim, and I am here to present the findings of our study, which is titled as Stakeholders' Experiences of Virtual Instructions in Post-RN Baccalaureate Nursing Program during COVID-19 Pandemic. My research team members include Arusa Lakhani, Saima Sachwani, Shinaz Qasim, Zinar Salim, and Rida Feroz. So what actually prompted us to work out for this study was the closure of educational campuses and suspension of conventional face-to-face teaching globally and locally. In lower middle income countries, higher education is predominantly offered face-to-face. However, many higher educational institutions were switched overnight to complete online delivery of education. Additionally, lack of online infrastructure at the university, students and the faculty homes, including limited access to the devices, network, unstable bandwidth, rapid power failure, as well as limited teacher and student preparedness made it challenging for resource-limiting countries. Two other studies from Pakistan also reported dissatisfaction with online migration in this new normal. Despite having blended learning experience, online teaching and learning is a completely new shift for all the stakeholders at School of Nursing and Midwifery, Pakistan. Having said that, the purpose of our study was to examine stakeholders' experiences of virtual course instructions, which include teaching and learning pedagogies, accessibility and assessment in post-RN baccalaureate nursing program during COVID-19 pandemic. Furthermore, to explore the strategic directions to streamline the online teaching and learning process in future. We came up with the following research questions. What are the perceptions and the experiences of stakeholders with virtual course instructions amid COVID-19 in post-RN BSc program? What are the benefits and the challenges of virtual course instructions amid COVID-19 in the post-RN BSc program? And what are the recommended strategies and way forward solutions to improve the online teaching and learning experiences of our stakeholders? We adopted qualitative, descriptive, exploratory design with purposive sampling technique. Our stakeholders were students, faculty, and the key informants from undergraduate program. After the consent and the demographic information, focus group discussions were conducted for the faculty and the students, and the in-depth interviews were taken from the key leadership using the semi-structured interview guide. The data was recorded, transcribed, manually coded, and analyzed using the Miles and Huberman guidelines. The demographic data revealed that majority of the participants were from the metropolitan city having internet accessibility. However, the bandwidth kept on changing. Approximately 80% of the students had an access to the internet, whereas 8 to 10% of the students residing in the northern part of Pakistan had to commute to the central hubs to secure the internet connection. Wide majority of the participants had minimal to no training when migrating to online modality and struggled to connect to continue their teaching and learning. Approximately 75% of the students commonly utilize WhatsApp groups and found it useful for seeking instructional support and connect with peers and the faculty. Most faculty members had internet connection available at home and expressed moderate to high satisfaction with the technological support available to them from the university. The content analysis uncovered three major themes: a paradigm shift in learning, diverse experiences and the perceptions, and multifaceted factors and the challenges. Participants considered the complete remote transition as a complete paradigm shift where they unlearned the conventional method and learned teaching and learning online while simultaneously planning and conducting instructions and assessments. Students and faculty voiced diverse experiences with online mode, some considered to be a blessing in disguise and embracing the opportunity during the difficult times of the pandemic, whereas others felt it to be distressing, demanding, and distorting their work-life balance. Numerous multifaceted personal, environmental, and socio-cultural factors were revealed that were facilitating. However, it challenged the participants and affected the quality of teaching and learning process. The study came up with the following way forward and the recommendation pointers. Continuous capacity building trainings for the students and the faculty, and the orientation sessions before the start of the semester should be offered to improve the teaching and learning process, and this proficiency in handling the digital tools, apps, and softwares will smoothen the teaching and learning process. Nursing education is incomplete without the clinical hands-on, and to ensure the robust learning process and to develop the competency, for some courses, virtual simulation strategy and the preceptorship model was recommended to get the real experience and student clinical engagement. However, for certain, 40% of the clinical hands-on is a must to get the exact flavor of the nursing psychomotor skills and actions, communication and assessment skills on the real patients on floor. Collaborative teaching and learning process to be explored across the Sonam campuses, as by embracing diversity and pluralism, it opens the doors for learning and innovation. In conclusion, this digitally enhanced pedagogy will facilitate the redesigning of the nursing curriculum for virtual course instructions and its delivery. It will also provide evidence-based solutions to embark on online teaching and learning transition. This study will also pave the way to initiate online higher education nursing programs for the nursing fraternity and the global alumni. And through this study, other nursing institutions in Pakistan will receive mentorship for online and distance nursing education. These are the reference for the study. Lastly, I would like to acknowledge the Department for Educational Development, study participants, my entire research team, and the senior leadership at Sonam for their consistent support, and DED for providing me with this opportunity to present my study at this platform. Thank you so much.
Thank you, Ms. Leila. So there's a question for you. Thank you for the wonderful presentation. Before I pose the question to you. So how did you probe the blessing in disguise of the online learning?
As I've said that in the methodology section, we created a semi-structured interview guides and the focus group discussions and the online, the IDI interviews. The majority of the data which came up, this COVID-19, provided this opportunity to, because many of the students in the post-RN BSc program are from diverse areas, such as are from diverse cultural background. They are married students who have and who are also doing their part-time jobs and everything. So this was a blessing for them that they can attend the online classes along with juggling their jobs, taking care of the home chores and the family. So, the large amount of the data that revealed and which we concluded at the time of the content analysis that, and we concluded that it was a blessing for those students and particularly the post-RN BSc and undergraduate program who are from the diverse classes and the categories.
Right. Thank you so much, Ms. Leila. If there are no questions from the audience, we'll move to the next presentation. Right.
Thank you so much, Dr.
Thank you. So with this, we'll move to the last but not the least presentation of the second session. Dr. Javeria Rahman from Department for Educational Development, Khan University. She will be presenting on mentoring experience and perceptions of mentors regarding mentorship program, a newly established medical institute. Dr. Javeria Rahman is a joint appointee between Department of Pathology and the Department for Educational Development, University at Khan University. Javeria.
Thank you, Dr. Tabassum. So I'm here today to present my work with my co-authors on mentoring experience and perceptions of mentors regarding mentorship program at a newly established medical institute. So mentoring in medicine, as we all know, is an enduring process that plays a pivotal role in the personal psychosocial development of the mentee, as well as a career advancement during professional transition of the mentee. As defined by the literature, process whereby an experienced, highly regarded, empathetic person, which is the mentor, guides another individual, the mentee, in the development and re-examination of their own ideas, learning, and personal professional development.
So the medical students, as suggested by the literature, face excessive academic stress and hectic schedules in their medical schools. So in order to enable them to seek the support system and provide them a better learning environment, an effective formal mentoring program is imperative. Therefore, keeping in view the crucial importance of the mentorship program, a newly established private medical institution in Karachi initiated a mentorship program for first-year medical students, where they included 100 students of first-year MBBS, and the mentor-mentee ratio was 1:10. Now, several researchers in the literature suggest the studies on the experience, perceptions, and implications of mentoring for the mentees, but a little has been explored in this regard for the mentors. Therefore, the objective of this study was to explore the mentoring experience and perceptions of mentors regarding mentorship program at this established medical institute. It was a cross-sectional study, and all 10 mentors were involved in the mentorship program for first-year undergraduate medical students. And the data was collected through a self-reported questionnaire that consisted of about 14 questions of both open and closed-ended variety. The responses were analyzed to determine their frequency for each closed-ended question. And for the open-ended questions, each response was studied and similar responses were grouped together to be reported. So the mentors included, majority of the mentors included those of the designation of assistant professor, about half of them, and the rest were from the initial career level, that is the senior lecturer or the lecturer. And the teaching experience, however, for majority of the mentors was found to be less than 10 years. Regarding the questions that they enjoyed the experience of being a mentor, although majority of them did not have a previous experience of mentorship, as suggested by the result, for about 60% of them, they enjoyed all of them enjoyed the experience of being a mentor. As you can see, majority of the mentors were able to resolve and help out the mentees' problems. For about 80% reported that they were able to resolve the mentees' problem in some way or the other to some extent. And for about 80% were motivated to be a mentor in future. Regarding some open-ended questions, the mentors responded as describing their experience of this mentoring as a self-motivating, satisfying experience with a sense of achievement for being able to address the problems and support the mentees in their issues. The professional development, improving leadership and communication skill was seen as a greater advantage for the mentors themselves. And it also helped them in promoting teacher-student interaction, thus establishing an effective mentor-mentee relationship. However, there were also some problems that they were encountered with, especially a majority of them reported the lack of interest or commitment by the mentees as a major problem, other than the administrative issues. The strengths identified by the mentors for this program was developing a support system for the students, increased student-teacher interaction, improved communication skills, the teamwork, students' involvement in decision-making, and improvement in attitude, learning, and motivation of the mentees. The weakness reported to be lack of one-to-one meetings, administrative issues again, and the inability of the students to make full use of the benefits of this program. So the mentors' experiences and their effects have been identified as the strength of the program, which is in accordance with similar experiences that have been reported in the research, in the literature, and strengths have also been identified as the strengths in several other studies. Many studies in the literature suggest increased academics performance and motivation for the mentees in the mentorship program, as this was also reported in our study. Hussain et al. And Rico et al. And several other studies also reported the lack of interest and commitment and diverse attitude as major problems that mentors encounter from their mentees. Various studies support the notion that insufficient time or low frequency of mentor-mentee meeting is a significant barrier in effective program, both for the mentors as well as for the mentees. So in conclusion, all the mentors in this study demonstrated a positive response regarding their perceptions and their experiences of mentoring. And despite the identified problems and barriers, majority of them were fully motivated to be the mentors again. Apart from sufficient time allocation and administrative support, mentoring workshops for mentors training is recommended. The future research on evolution of the program over the time, as well as its evaluation, and how the differences from initial design and implementations are reflected in the program outcomes is also one of the recommendations. So these are the references in support of the study. And thank you very much.
Thank you, Dr. Javeria. So, very nice study on mentoring program and the implementation at a private sector university. So the question is, how was the improvement in students measured with respect to the mentoring process?
Right, thank you for the question. It wasn't measured explicitly, but in terms of the improvement seen or observed by the mentors in the academic performance and the general behavior attitude of the students, it was perceived response by the mentors over the period of time of that 1 year that the data was collected, that this is what they perceived actually, that they could see the improvement in their mentees in terms of those education as well as behavior and attitude and learning.
Right. Are there any further questions from the audience? Okay, I could see that there are no further questions.
Thank you.
Thank you so much, Dr. Javeria. And now we move on to the summary of the oral presentation. For this, I would like to request Dr. Amreen Usmani to please provide a summary of the presentations.
Thank you, Dr. Tabassum. First of all, congratulations to the DED team. Dr. Tariq, thank you for inviting me. Dr. Sonia, thank you so much. And it's always an honor to be with you, ma'am, Dr. Ruxana. It's really been a lovely experience here. So in a nutshell, Dr. Khala was the first one to present, and she presented on motivation and its impact on learning capabilities. It was a good presentation. However, she said that the conclusion that low motivation during the COVID-19 was felt in her study. Then we went on to Ali Ahal, a fantastic presentation, Ali. He spoke, I really wonder how he got hold of so many students, 3,800 students. That is amazing. That is truly amazing. He spoke about comprehensive strategies for research skill education and the significant improvement due to the national workshop that was conducted by the team and himself. Then we went on to Leila Akbar. An excellent presentation, Leila, very nicely presented on virtual learning and online learning, and the pitfalls that you mentioned were faced by many of us, and they were very nicely presented. And you said that it would facilitate a redesigning of the curriculum and its delivery based on the experience of the stakeholders. So I'd like to congratulate you too on the excellent presentation. The last presentation was by Javeria Rahman on mentoring, and she spoke about the mentor-mentee relationship, and they had a good ratio, that is 1:10, and the effects that it had on the mentor. So this is a very hot topic nowadays, and everyone is actually working on this particular philosophy of how the mentors and what effect it has on the mentees. It has many good effects, as pointed out in the conclusion. It may have bad effects too, but that can be another research. So thank you very much, everyone, and congratulations. Thank you so much.
Thank you, Dr. Usmani. So we now conclude this session, and we have a short 5 minutes break. So in this break, who have joined us virtually, please enjoy with the glimpses of our previous research days. And for the audience who is here physically, we'll be back in 5 minutes time. Thank you.
Welcome back, everyone. And we now begin with the third session of oral presentations. We have 4 presentations of 8 minutes each. And we will have question and answer at the end of the presentation. And I would like to invite the first presenter, who is Dr. Tabassum Zehra, Assistant Professor in the Department for Educational Development, Aga Khan University. The title of her presentation is Basics of Faculty to Faculty Mentoring, Support and Challenges. Dr. Green will be joining, so I think we'll wait for a minute.
वो थोड़ा delay.
Thank you so much, Dr. Raila. So the topic of today's presentation is Basics of Faculty to Faculty Mentoring, Support and Challenges, and the study was conducted by myself and my co-authors from Department for Educational Development, Aga Khan University. So this is the disclosure statement. So what does the literature say? So mentoring has been a relatively new concept in the health sciences, and it has not been a common practice in lower middle income countries. And there has been a dearth of literature with respect to the formal mentoring from the subcontinent, although it has been reported in the developed countries. So mentoring for the faculty development in medical education has been a virgin territory. So the role of mentor may be informal, and that may pose challenge and requires dedication and time. A good mentor-mentee relationship contributes significantly to mentees' career development and satisfaction. However, mentoring program in developed countries have been successful, whereas in the underdeveloped or the developing countries, it has not been reported as much. So what is faculty mentorship? So the literature says it has been reported as a process whereby an experienced, highly regarded, empathetic person, which is known as a mentor, guides another, which is usually a younger individual, the mentee, in the development and re-examination of own ideas, learning, personal and professional development. Roles and responsibility as reported in literature relate to different categories, which may be the professional development, emotional support, intellectual committee, access to opportunities, providing feedback, sponsorship, holding accountable, providing safe space. However, all these roles may not be served by each faculty mentor, may not fit for all, may not be fitting for all possible roles. The mentoring relationship is most effective when it has open communication accessibility, the goals and challenges are agreed upon, they have been discussed, there's a passion and inspiration from both the parties, there's a caring and personal relationship, and there's a mutual trust and respect from both the parties, like mentor and mentee, there's exchange of knowledge, independence and collaboration, and role modeling from the mentor. If we look at different aspects between the relationship, we see that, 3 important aspects are being considered in literature, which are related to the relational component, like it relates to basically the mentor-mentee relationship. Then it talks about the developmental component, which is basically the process where, it talks about the development of the mentee, and then the contextual component where the institution plays its role. So much have been reported on the mentor-mentee relational component and the developmental component. However, the contextual component is still not being reported very much in the literature. So basically, what faculty members or which faculty members need monitoring? It has been said, yes, that assistant professor level needs the most mentoring process they need the most kind of mentoring. However, literature also reports that all faculty members need mentoring, be it clinical, full-time or non-full-time faculty, associate professors or full-time professors. However, their need may be different. So the progression and professional development need may be different. So what was the background to hold this this research? So AKU has initiated faculty mentorship forum, which is for the faculty to excel in academic environment, because there has been a mentorship program for medical students. However, for the AKU faculty, this was a new concept, and this was long awaited. So the importance of faculty mentoring has been flagged at multiple fora, and there was no standard faculty mentorship model that was available for AKU faculty. So there was a series of workshops that were planned for the faculty members of the medical college, and all full-time faculty members were considered for this workshop, and the objective was to promote a structured faculty mentoring program. And obviously, responsibilities and expectations will also need to be identified, and the challenges with respect to the faculty mentoring were to be discussed and to be identified. So what we did was we conducted a workshop, which was basically at AKU, and around 22 faculty members from the medical college joined the workshop, which was based on the observational study design, and we included all medical college faculty mentors, which were registered or basically assigned with the Faculty Development Forum. And we did not include any of the faculty who were not registered or were not under the Faculty Development Forum. So basically, we went through the expectations, identification of the expectations from the faculty mentors, basically because this was a very basic kind of a workshop that we did, and we wanted to identify the needs and their expectations. And we talked about the mentor responsibilities with the perception of the faculty mentors that are already enrolled as mentors, and what do they think the mentee responsibilities are, and what would be the institutional responsibilities with respect to faculty mentorship forum. And during this process, we also, walk them through the mentor-mentee relationship with respect to promotion, personal and professional development, and they had experience in a simulation environment. Though this workshop was on a virtual platform, but it went, to experience them in this role plays. So this is just a few glimpses of what kind of workshop we had, and the faculty members that had joined us as mentors. So the faculty expectation, what came out of the faculty expectation was basically that they wanted to know the technicalities of being a mentor, experiencing from others, right? Like peer learning, and then the interaction and communication between mentor and a mentee. This was related to the relationship. They wanted to know about meaningful contribution and development of the mentee, scientific tools that are available, how do they deal with formal versus informal kind of a mentorship, and they wanted to know more about the mentorship process, the support that is available, and the responsibilities, not only for mentor, but also with respect to the mentee, and what would be the basics. They also would like to know the impact of mentorship. And this was something that we said it's not something that can be noted or observed in a short time period. But yes, once this has been formalized and has been instituted, only then the impact could be monitored and can be reported, which will be one thing that we will look forward. So the results of the expectations and the responsibilities and roles that the faculty mentors reported or perceived were, for the mentor, they said that mentor need to support the mentee, helps them developing a career path, flourishes the capabilities of the faculty mentee, demonstrate interpersonal communication skills, knows own limitations. So this is, if you note, the highlighted ones are those which were not reported in literature, and these were the ones that came out of the discussion from the faculty members. Respond to the emotional needs of the mentee, and then observe actual progress, give constructive feedback. Then if you look at the mentee, apart from all others responsibilities that were also reported in literature, recognizing and accepting faculty as a mentor was one thing that was not being reported in the literature, and having an action plan, though feedback was very frequently reported in literature, but having an action plan following the feedback was not there. And with respect to the institution, creating a culture of mentorship from top to bottom, this was something that came out from the discussion, which I could not come up with any kind of literature reporting this. And then provide a formal mentorship training program, providing resources and the framework for ground rules. So a couple of things that came out very interesting out of the discussion. Then what were the challenges? Because we also talked about if you are a mentor, what kind of challenges do you face? And what do you see to mentor? Being a mentor is a challenge. So they said that creating balance between service, teaching, and research, sorry for the typo, this was one of the challenge that they see. Like, they thought that giving optimal time to mentoring is something that is needed. Optimize meaningful relationship. This is what they thought they needed. And formalize faculty mentorship program. This was coming from one of the chairs. And the framework required in academic setting, this needs to be very clear. And ability to absorb anything. This is something that the mentor need to build in. And mentor should have an honest assessment of the mentee. And role modeling was one thing that was very difficult for them or challenge for them to be as a mentor. Then there were other allied factors, and they wanted to learn more from mentorship opportunities. So if we see, there are certain roles that are being reported in literature, and they're very much the same. Like if you see, only the wordings may be changed, but essentially the concept is the same that has been reported. However, if we see with respect to the socialization of profession, positive role modeling, leadership skills, and portfolio preparation, these are something that were not reported neither in the discussion nor were reported anywhere else in the literature except for one of the institutions that had surveyed their faculty. So I think this is something that we need to also cater to and need to focus while we are developing or initiating this kind of programs. So the conclusion is that evaluating potential mentors using discrete criteria can help you identify suitable faculty with whom to work. Mentees have a major role in fostering and promoting a mentoring relationship. And consistent communication and aligning expectations between mentor and mentee are critical to success of the mentor-mentee relationship. So the conclusion and the way forward is that AKU has initiated this mentorship awards, but faculty still needs motivation, right? There are instances where faculty needs more motivation and more awareness with respect to the mentoring process and aware of the roles and responsibilities. We will be moving towards an advanced level workshop for AKU Medical College faculty and expand this workshop to not only to AKU Medical College, but also to School of Nursing and Midwifery, FHS, and maybe beyond, right? So thank you so much. If you have any question, I'll be happy to answer. Thank you.
Thank you, Dr. Tabassum, for a very nice presentation and a much burning topic. Any questions from the audience? Yes. Mike, please. Yes.
So thank you. I'm Salima, Dr. Tabassum from Sonam. It's such an insightful presentation. So I really appreciate you and the entire team to present and conduct this important project. So my question about when you mentioned about the formal and the informal mentorship, where would you place AKU in terms of the formal mentorship program? Do we have that structures in place? And what do we do? What is the first immediate step would you propose after, concluding this project? So your viewpoint about it.
Thank you. Yes, a very nice and important question. AKU has been looking forward to have a structured and formal, faculty mentorship program, which is basically for faculty to faculty mentoring. This was initiated a couple of years ago, maybe for not more than 5 years ago. And however, informal mentorship has been going long way back, like from long way back. We know that we do some informal mentorship day in and day out. So this structured faculty mentorship forum is there, which has been initiated by the Associate Dean faculty, who has recently joined. And now, because of this forum, the institution is looking forward to have a structured and planned mentorship program. So this was the first workshop that we conducted from the platform of DED. And this was to initiate the expectations and the ideas and the needs, basically, of what the faculty need, right? Are they aware of the roles and responsibilities? Do they really know how to go into the process? Do they really know how to develop that kind of relationship? So that was the basic workshop, and we looked into the support and the challenges that the faculty have. Now the way forward is that we will be moving forward with such kind of workshops, and be moving how they can develop themselves as mentors, right? And we will include all of the faculty mentors who are under this umbrella of the Faculty Development Forum. So this is the idea basically, and these kind of workshops will be repeated frequently, so that they have a grasp of the knowledge and the processes that are involved in maintaining this kind of relationship. So this is the plan and the way forward. And we always have a plan to move to the School of Nursing and Midwifery as well. Yeah.
So thank you for saying
Yeah,
that.
Thank you.
Thank you. We now move on to the next presentation, which is by Namra Qadir, AKU, on impact of communication skills training on surgical care, a mixed method study at LMIC. Namra.
Assalamu alaikum and a very good afternoon to everyone. First and foremost, I would like to take this opportunity to thank the organizers for this prestigious occasion to let me perform today. So the title of my presentation that I will be presenting on is the impact of communication skills training on surgical care. This is a mixed method study that we conducted in a lower middle income country. So starting off with the background, it has already been well established that physician-patient relationships, it has already been well established that physician-patient relationships are a core element of quality healthcare, in that the patients, when they interacted with a healthcare worker who had received prior formal training in communication skills, were actually found to give a higher patient satisfaction rate. This is evidenced by the fact that there are certain specialties that require a higher clinical expertise in communication skills, such as the field of surgery, which requires a multidisciplinary approach, complicated procedures, and invasive interventions. While there is vast literature and evidence from the West to support the importance of communication skills, however, literature from our part of the world, which is the lower middle income countries such as Pakistan, severely lacks, and we do not really know what the communication skills expertise of our healthcare workers are, or the utility of training interventions that could be implemented, and how they would work in improving the healthcare delivery from our part of the world. Hence, we conducted a mixed method study to explore the existing problems of communication skills and professionalism exhibited by surgical residents, and to identify the need for a formal and standardized communication skills curriculum. For this, we conducted a mixed method study which had two arms, quantitative and a qualitative arm. For the quantitative arm, we collected data using a self-administered survey, which focused on the communication skills expertise of the residents. The survey question was based on a Likert scale, which ranged from 1 to 5, where strongly disagree was 1, disagree was 2, neutral was 3, agree was 4, and strongly agree was 5. For the qualitative arm of our study, we conducted 5 focus group discussions with 41 participants that included 14 residents, 10 attendings, 11 medical students, and 6 fellows. We conducted these focus group discussions using a semi-structured interview guide with a focus on communication skills expertise amongst the residents. These interviews were audio recorded, transcribed verbatim, and thematic analysis was conducted using NVivo software, and 2 independent members of our research team actually conducted this analysis to maintain the credibility of our findings. The study tool that we utilized was essentially adapted from a survey in India, and they developed it based on extensive literature search, multiple rounds of focus group discussions with the residents, as well as consensus from educational experts from that part of the world. The question here had several components exploring different aspects of communication skills among the residents, and these included self-assessment of communication skills, barriers to good communication skills, prior communication skills training, the need for a training intervention, and if the patient-physician conflicts that the residents might have encountered throughout their training. To gain a holistic understanding of the status quo of communication skills among our residents, we decided to target 4 key cohorts in which the residents served as the target study population of focus, but we also utilized attendings, fellows, and medical students as key informants for our study. So moving on to the results, we received a total of 155 responses. These included 33 surgical residents, 22 fellows, 58 medical students, and 42 attendings, all hailing from various surgical subspecialties at our institution, including general surgery, obstetrics and gynecology, neurosurgery, urology, orthopedics, and otolaryngology. As you can see at the bottom right corner, a majority of 58% of our respondents actually identified that they had not received any formal training in communication skills, and that whatever skills that they currently had were actually acquired second-handedly by observing attendings, their own colleagues via peer learning, or observing their senior residents as well as fellows, or themselves actually via trial and error method. This is essentially an analysis of the Likert scale that I mentioned. So it ranges from strongly agree to strongly disagree from left to right. And on identifying barriers that prevented the residents from employing effective communication, we actually found the highest agreement on long working hours, which was closely followed by human failings such as stress and fatigue, and lack of training in communication skills. The other factors that were identified included the lack of subject knowledge on what diseases and conditions that they were counseling the patient on, and infrastructural deficits such as a lack of designated counseling spaces in our institution. However, it's very interesting to see that lack of insight was actually found to be the most significant contributor, with a p-value of less than 0.01, where the residents actually did not regard communication skills as being equally important as the medical management of diseases and patient care. When queried on if there was a need for a formal communication skills curriculum, an overwhelming majority of 77% of the respondents actually mentioned that there was a need. And when queried on what this new curriculum, if developed, should focus on, they identified several subject areas. However, highest agreement of 70% was on that it should encompass general communication skills. However, certain key components were identified, which included communicating with angry patients, breaking bad news, how to disclose diagnosis for the first time. Additionally, there were also other key skills that were mentioned, which included explaining delays in waiting times, especially in the OR, inter-team and intra-team communication, and also the very important concept of non-verbal communication that comes into play. I know it's a busy slide and I'll walk you through it. So this is the result of our qualitative analysis. And through this, we identified several sub-themes, which included the residents mentioning that they were mostly being overworked and exhausted so that they could not find enough time to properly sit and communicate with the patients. They identified that there was a lack of designated counseling spaces and there was a lack of role models. Interestingly, some of the medical students actually identified that they found the residents exchanging patients between them based on the patient's gender, on who they feel more comfortable working with. So for example, a female resident would get a female patient because they feel more comfortable working with them. Moreover, some students also reported that they saw the residents interacting with patients differently based on their socioeconomic status. So for example, if there was a patient that belonged to a lower socioeconomic class, or his education status was not up to the mark, then there was a certain degree of dismissiveness in the resident's attitude while talking to the patient. Several key subject areas were identified so that when the communication skills curriculum, if it is developed, what it should focus on. And the residents mentioned that communicating with their relatives, how to break bad news, or how to gain informed consent. They also suggested a few strategies that can be implemented in developing this new curriculum. So these included simulation-based learning, scripts, and role-playing, because the residents mentioned that whenever they find themselves in a critical situation, the first thought that actually comes to their mind is that they've never faced such a situation before. So if they had these sessions of role playing and script writing, then that would really help them prepare for such situations in the future. They also mentioned that timely feedback from the attendings, where they can have a structure where the attendings are actually observing the residents while they're communicating and counseling the patients, and give them feedback based on that, would really help in their learning. And timely implementation of these interventions right towards the start of their residency training, so that over the time of their residency, they can actually brush upon these skills. So in conclusion, our study highlights that communication skills training should be imperative amongst healthcare workers, because a lack of communication skills can serve as a major barrier in providing optimal care to the patients. And hence, we identified that there is a need to develop a standardized communication skills curriculum, which should encompass several aspects, such as communication abilities, interpersonal skills, and professionalism, especially for healthcare workers who are training in our part of the world, so the lower and middle income countries such as Pakistan. Thank you so much. If there's any questions, I'd be happy to answer.
Thank you very much, Namra. A very interesting study with interesting conclusions. And one question is, what does your group feel is the way forward, taking the results that you have got?
Thank you so much for this very important question. So to give you the bigger picture, my study is actually a very small aspect of a much larger study, which is, so right now we're at the first phase of a 5-phase study, in which firstly, we identify if there is a need for a communication skills curriculum, which we have. Moving forward, we will use this evidence to develop a communication skills curriculum, working with the PGME department, as well as conducting a Delphi consensus, which would be the second phase of our study. So for that, we will invite educational experts from not only our institutions, but from all over Pakistan, as well as international educational experts. And we'll combine all of this information and expert opinion into making a curriculum. And the hope is to implement this curriculum in AQ and see how it works. If, inshallah, it does turn out to be successful, then we're hoping to expand this curriculum to all over Pakistan. And hopefully in the 6th Educational Research Day conference, we'll be able to talk about how we develop our curriculum and if the intervention was actually successful.
Thank you, Namra. Just to add what Namra said, the future plan is to expand this and to developing a curriculum by including experts, and experts would include all the PGME directors, PGME associate dean, as well as section heads, as well as dean, as well as DED educational experts. So उन सब के साथ मिलके whatever they are doing good, that would be included. Whatever new is coming up, a success based on the needs analysis, a combined, agreed upon consensus के साथ Delphi technique से एक curriculum develop initially for few programs, and then it would expand to other programs as well as nursing and for faculty as well. So ये जो bigger picture में basically ये plan है. Just want to give you a bigger picture on that. Okay, thank you.
Thank you very much. Thank you very much. And it will be very interesting to see the new curriculum and the implementation of it, and looking forward to seeing its results in the next research day. So with this, we move on to the next presentation, which is by Nosheen from University Hospital of NHS Trust UK on patient communication skills among Bangladeshi medical students. So Nosheen is joining us online. Nosheen, are you there?
Yes, I am. Can you hear me?
Yes, we can. We can.
I'm just going to share my screen here.
Yes.
Is my screen visible there?
Yes, it is.
And the slideshow is on, yeah?
Yes, yes. Over to you, Nosheen. Thank you.
Yeah, thank you so much. Assalamu alaikum, everyone, and thank you so much for this opportunity to present in this wonderful conference. So I am Nosheen Sayara. My topic is patient communication skills among Bangladeshi medical students, and my co-authors are Faridul Islam, Maria Akhtar, and Umme Habiba Akhtar. So moving to my introduction, I think that we can all appreciate the fact that the interaction between doctors and patients are a very important part of our medical care, especially in the era we are living in. We have to take patients' emotion as equally as we take their clinical conditions. So even if we are clinically very skilled and knowledgeable, we can still leave a patient not fully satisfied if we can't properly communicate with them. Especially when it comes to countries like us, like Pakistan, Bangladesh, where given the literacy of people and understanding level of people, I think it's very important that we make ourselves very considerable to the fact that if the patient is getting what I'm saying or trying to explain to them. So what we did is we wanted to know that how are we teaching our students, because when we become doctors, it becomes a part of our day-to-day clinical practice to communicate effectively with patients. So are we giving the students enough training on that as we are giving them clinical knowledge and practical skills? So we conducted an audit. We interviewed 26 participants who volunteered for the study. Of government and private medical colleges in Bangladesh, and we saw how their communication skills are based on a breaking bad news scenario. So when it comes to breaking bad news scenario, a spikes format is widely used worldwide, which stands for, this is basically a mnemonic which stands for setting, perception, invitation, knowledge, emotions, strategy. So this format sort of helps us to effectively break a bad news while keep maintaining a proper pace in keeping with the patient's emotion and understanding. So just to give you a quick glance, we made a questionnaire of 20 questions. Comprising of first asking the patient how they are feeling and what they know so far, and giving them a warning call that we are going to give them a bad news apparently, and then going not too fast, not too slow, and checking their understanding periodically to make sure that we are on the same page, and showing empathy throughout our voice and body language, and overall allow some silence, allow some time during the news breaking. So moving on to result, we saw that how many students actually followed this format, or at least these steps. So among 26 students, we found that 30% checked that the patient's condition and understanding before breaking the news. Some patient might have known a little bit that, okay, they have got this condition. and then 23% gave them a warning call. So 73% of the students maintained a steady pace while giving the diagnosis to keep up with the patients emotionally. And more than 70% students gave time for questions, but almost 60% of them did not allow silence after the news, which we all know in clinical practice is very important because they have to process the news about themselves or their family members. So we found that approximately 69.2% of the students provided adequate information about the disease, maintaining a sense of hope, and 65% recognized emotional expression of the patient and allowed time to express it. And only 19% could inform the patient about the potential next step and person to contact. So looking at this overall result, I would say that when it came to giving them time or maintaining a steady pace, we have a very good result. Above 70% of students actually followed these steps, whereas checking their understanding before actually going to the bad news or giving them a warning call or recognizing the emotional expression of the patient, we have got like percentages below 70%. So we still got some work to do here, I believe. And about the potential next step, they are only medical students. So this is something that we actually did not expect them to do very enthusiastically. So this is the overall bar chart showing the percentage of students who actually followed all these questionnaires. So it was a overall scoring system that we followed to see how they break a bad news to a patient. So looking at this, that from third year, Bangladeshi medical students go to wards and learn clinical knowledge and skills from seniors. But we do feel like in this communication part, we still have got some training to do. We still need to teach them how to actually communicate with the patient when it comes to sensitive cases, like a breaking bad news or declaring a death, this sort of situations. So I conclude with the thing that sentence that empathy and professionalism shape a patient's experience almost as much as diagnostic ability or surgical skills. Many doctors carry the weight of breaking bad news to their patients, but kind words can soften the blow of it and undoubtedly ease the burden. After all, there is no greater comfort than human connection after all. So there is a great saying by Peter Drucker that the most important thing in communication is hearing what isn't said, which is, we believe, very important for us, the doctors, because we deal with very sensitive conditions and human life here and human emotion. So we have to be very careful when we speak to patients. And I think that students should be taught about this from an early period, then later on going on in a clinical career and then finding all these things out. Thank you everyone very much again for this opportunity. And I wish you all very best. Thank you.
Thank you, Nausheen. Thank you for a very interesting presentation. And we are now open to question and answers. Any questions from the audience?
Thank you, Sarah, for a very good presentation. I'm Dr. Tabassum Zara from Khan University. So my question is that in one of your items, you did say that the item asked about allowing silence, and the students did respond to that, right? I just wanted to know whether you had a detailed narration of what does allow silence means, and were the students able to interpret what that item meant? Because in your results, you did mention it allows silence after counseling, but in your results, it did not mention whether the item was narrated in that form or not, right? It was written in that form or not. And secondly, you said that third year medical students need to be aware of the need, right? So in your study, you talked about asking the students about whether they were able to or to practice these kind of behaviors. And in the second instance, you're also saying that third-year medical students need to know. So would you please like to clarify what was the basic aim of this study? Would you like to you identify the needs, or you'd like to know whether they're practicing or not?
Thank you so much for your question, ma'am. So basically, starting with the first question, this questionnaire was, we built it up to see how they do with their Breaking Bad News scenario. This was not given before the scenario to them. So at first, we just gave them a scenario. The students were mostly from third year to final year medical students, because they are in the clinical attachment at this point of their curriculum. And we gave them the opportunity to do the communication spontaneously, and we scored them based on these questions, because these points are worldwide accepted when it comes to a Breaking Bad News scenario that we practice in our everyday clinical practice. So after they did the scenario, then we provided them with the score sheet, and then how, as I say, that this is not like you have to follow all these 20 points point by point. This is just a worldwide accepted points for us to make ourselves like more formatted and more comfortable with a sensitive situation like this. And as I said, it's not that from third year they need to know it. I said that from third year they are going to wards, they are dealing with patients directly, because first year, second year is mostly theoretical, but from third year they are starting to go to the wards, they are coming in touch with patients. So if we can give them little bits of idea from that year, maybe by the time they come into fifth year, final year, or their internship, they will know better about communication than they would know without any sort of training or teaching. So that was the main point that I wanted to make. I hope it makes a little bit more sense now.
Yes, thank you very much. So with this, we now move on to the last presentation of today, which is by Jabin Fayaz, who is joining us from the Hospital for Sick Children, Toronto. And the topic of her presentation is Simulation Beyond Sim Centers, Virtual Simulation Experience Using Virtual Resuscitation Room, VRR, for Pediatric Emergency Medicine Learners during the COVID-19 pandemic at the Pediatric Emergency Department of the Hospital for Sick Children in Toronto. So Jabin, are you there?
Yes,
Yes.
Can everybody hear me?
Yes, good to see you. Yes, we can hear you.
Sure. I'm going to share my presentation. Is it visible now?
Yeah, yes, it's visible. So
Perfect.
over to you now.
Thank you so much. Assalamu alaikum, everyone. And it's kind of an emotional and honored movement for me just to be back after so many years among the community of educators and leaders from DET. So thank you so much for providing me this opportunity. So I'm going to share my study titling Simulation Beyond Sim Centers, which is a virtual simulation experience using the virtual resuscitation room for the pediatric emergency medicine learner during the COVID in our department. And it is not my work only, there are many co-authors and collaborators along with it. So no disclosure or conflict of interest. Coming to the background, we all know that simulation is an important part of educational curricula, especially the acute care curricula, because we have hello events which are high acuity, low occurrence, and we have to train our learners in a simulated environment. But when the COVID hit, the simulation centers requirement for in-person, face-to-face simulation changes, but the learners' need remain the same. So there is a big opportunity or big kind of a gap where we have to find out how to fill those gaps or develop some enhanced curriculum, alternating with the face-to-face simulation, which lead to our exploration that what are the literature has in terms of how can we enhance their learning experience. So the goal of my project was to develop a virtual simulation program for pediatric emergency medicine learner during the COVID at the Hospital for Sick Children using the virtual resuscitation room, and to assess the faculty and learner satisfaction and feedback regarding the virtual simulation program. So our population are we included the residents, fellows, and faculty member with telesimulation using the virtual resuscitation room, which you can see on the right-hand side of the slide. We compared the evaluation from the in-person simulation with the virtual resuscitation room simulation, and then the outcome measures for the evaluation scores, and also the open-ended feedback and educational engagement by the learners as well as by the faculty members. So why we chose the virtual resuscitation room? Because it is very easy to utilize. It just need a laptop with an internet connection, any of the teleconferencing meeting platform, which can be Zoom, which can be Teams or Meet or anything else. It is not a share screen. It is a different model which we created on a Google slide where multiple participants can go into the slide and then perform different tasks. So there's a link of Google slide that we will share with the learners. So this is how our first interface of our virtual resuscitation room look like, and you can modify it any way. The outlook of the patient, which is here, you can change its appearance, and then it has got some of the component with airway equipment, with the monitors, with the basic application of like your pulse oximeter, BP cuff, and then at the left-hand side, you will see a recorder sheet, which is very important to have those roles while you are running a resuscitation. The second phase is our virtual medication card, and the third is the virtual airway card. So the implementation roadmap is we developed cases on the virtual resuscitation room. We conducted faculty and facilitators training, and then we developed virtual simulation guidelines as well as debriefing checklist for the facilitators as well as for the learners. Coming to each session comprised of 5 to 6 learners per session, and they have been provided beforehand the virtual session checklist and ground rules. There were 2 facilitators were co-facilitating each session, with a training of those facilitators conducted before recruiting them or before letting them to facilitate. And again, a virtual simulation checklist and ground rules were shared to them, and a mock dry run for novice facilitators were conducted. The duration of the simulation session was like 15 to 20 minutes of a simulation scenario, followed by a debriefing, which was conducted on a plus delta pulse debriefing model. And then at the end, there was a verbal feedback as well as a written on a red cap survey was seeked. So this is how like a glimpse of a virtual resuscitation room look like, where there are participants on the left-hand side, which comprise of a team, that is a team leader, a person who is doing an airway, bedside MD, a medication person, and the recorder, and they will be performing tasks simultaneously into this virtual simulation room, and then able to communicate to each other to practice the crisis resource management, which is an important part of managing any sick patient and dealing with the resuscitation that include leadership, communication skill, and closed loop communication. So I will skip the video because it might cause some troubles. So what we achieved by this program, we covered 30 sessions with 150 learners till January to date. The level of learners were including from junior learners, that is PGY1 and PGY2, to the PEM fellows and EM emergency medicine residents, along with the emergency medicine community physicians as well. 20 new cases were developed, and the best part of this platform was that you can tailor the case's difficulty according to the level of learner, and you can incorporate various layers of difficulty depending upon what are your objectives and what are you aiming to achieve from those sessions. The evaluation that we got are 135 in number, and we did not change the evaluations. We just kept it as it was for the in-person scenarios. So the first domain was the design of simulation session, and you can see it is quite comparable in terms of meeting their learning objective, sufficient time for the debriefing activity, physiological clues provided to them. The only a little bit difference between was the opportunity to summarize main learning point, and then simulation setup like props, makeup, etc., which is quite explainable in a virtual environment. But the second point, that debriefing provided an opportunity to summarize to main learning point, we just after conducting a couple of sessions, we emphasized this to the facilitator to make sure that those points have been summarized. When it comes to the facilitator evaluation, it was also comparable in terms of whether facilitators are able to support their learning, did they conduct the debriefing in an organized way, provided constructive feedback, and then provide a safe, psychologically safe learning environment. And then there was some differences in terms of reflecting on their own practice, and also roles and expectation, which is quite, again, self-explanatory, which is very difficult to have in the virtual environment. Overall satisfaction is also comparable to the face-to-face. Some of the comments that we got from the learners and facilitators about what worked well is they actually was surprised because it went well, or it was able to allude to crisis resource management. It enabled the participants to have an engaging environment, as well as able to debrief in a way which is quite psychologically safe than they initially expected. There was an engagement, and then they thought that the software worked well for them. Some of the things that can be done differently, which we keep on incorporating while we are longitudinally running this program, is limiting the number of the cases or provide more time for the cases. There was some of the platform issues where things were not fixed, like they were very movable and any learner can move it. So we make those changes, and then definitely they realize or recognize that this virtual platform has its own drawback, but they really appreciated the effort that has been done to let them participate in the simulation-based educational sessions during the lockdown. Some of the advantages that we found, it is collaborative. It allows interactiveness. It is responsive, that the participant facilitator can respond to the action while what learners are taking, and it's free and simple. Some of the barriers that we found are the faculty development, developing a simulation cases repository, realism, ensuring psychological safety and learners engagement is still a challenge. And then what are the best outcomes that we should measure while conducting these virtual simulations? Our future goals are to enhance the existing curricula with the virtual simulation, and to have more community outreach nationally and internationally. So these are some of the references. And with this, I will end my presentation for any question, comments. And I have my email address if anybody want to know more about this virtual recitation room. Thank you so much.
So thank you so much, Dr. Jabin, for a very nice presentation, and something that is very helpful for the current era that we are in. So there's a question that's coming in the chat box that how did you impart the psychomotor skills in a virtual environment?
Yeah, that is a very important and a valid question. The focus was mostly on the medical knowledge and the crisis resource management. Based on the limitation of this platform, unfortunately, we are not able to gauge the psychomotor skills, like in terms of their procedures. But yes, we are able to let them walk through the procedure, and they are inbuilt, like you can walk through the steps of the procedure. But yes, in terms of performance, it cannot be done in the virtual, in this platform specifically. So that's the limitation of it.
Thank you, Jabin. Any questions from the audience? No, I don't think so. So thank you very much, Jabin, for joining us. And I would now invite we've come to the end of the oral presentations, and I would now invite our judge, Dr. Naveed, for his summary.
Thank you so much for the opportunity to summarize the 4 presentations during session 3. All 4 presentations were excellently delivered, very good research work, and the evidence is that they maintained the attention and interest of the audience right through to the end. The first presentation by Dr. Tabassum Zehra was on faculty-to-faculty mentorship. It highlighted the lack of research and the lack of practice on faculty-to-faculty mentoring in developing countries. It was an excellent example of how the needs of the stakeholders can be determined before developing any capacity development program, and how the stakeholders can be engaged in sharing their own needs for the development. It also highlighted the expectations and roles of the mentors and mentees and of the institution for good faculty-to-faculty mentorship program. The second presentation by Namra Qadir was on impact of communication skills training on surgical care. Again, I would say a very good example as to how the stakeholders were engaged to identify the barriers and the needs, and further areas were identified to develop capacity development to improve the performance of the residents. The third presentation was on patient communication skills among Bangladeshi medical students by Nausheen Sayara. The highlight of the study was the assessment through simulation and observing the performance of the students rather than going through surveys or questionnaires. So this was a good learning point for us. And they identified again the need for enhancing the capacity development or the undergraduate medical education programs for this area. The fourth presentation by Dr. Jabin Fayaz on simulation beyond sim centers was an excellent example of simulation using virtual reality, which is the need of the hour, specifically during the pandemic. The study demonstrated good principles of course development, developing content, faculty development, and ending the cycle with evaluations. It also highlighted the challenges of introducing developmental programs through virtual reality. So thank you again for very good presentations.
Thank you, Dr. Naveed, for the summary. And with this, we come to the end of the presentations, and now time for some well-awaited announcements of the best oral and the best poster presentations. Before I invite Dr. Sonia Haider to announce the best poster presentation, I would like to thank all the judges of e-poster who took time out from their busy schedules to judge the posters. Our judges for the e-poster were Dr. Jacqueline Dias from University of Sharjah, Dr. Iram Khurshid from Ziauddin University, Dr. Nusrat Fatma Rizvi from Institute for Educational Development, AKU, Dr. Nida Najmi, Dr. Farheen Yusuf, and Dr. Alia Aziz from the Department of Obstetrics and Gynecology, AKU, and Dr. Azam Afzal from Department of Educational Development and Medicine. Thank you so much. And I would invite Dr. Sonia to announce the results of the best poster presentations.
Right, thank you very much, Dr. Javeria. So I think a lot of waiting is there, so I wouldn't take a lot of time. So I'll begin with in a descending order. So starting with Dr. Sana Said, who stood actually 5th in terms of the ranking, Department for Educational Development and Departments of Pediatric, Khan University. And the title was Combating with Challenges in Medical Education During COVID-19 Pandemic, a mixed method study identifying the effectiveness of using e-learning in pediatric clinical clerkship of a university hospital, Pakistan. So if you could kindly begin with a 1-minute presentation, yes, please do come on, guys.
Thank you very much, Dr. Sonia. So COVID has actually made us thought a little different. And so in pediatric clinical flagship, which is the prime location where the actually students are put in group of 5, batches of 5, 20 each, and they are rotated in clinics. Bedside teaching is usually happen, and they are taught using tutorials and lectures, etc. But during pandemic, we were at hold, and at that point in time, we created our e-learning module, and we tested it using pre-post study design, and then using a mixed method sequential design. And then we also conducted a focus group discussion to explore their experiences. And we found that there is a substantial contribution that e-learning could offer to sustain the continuum of medical education during the pandemic. So thank you very much.
Thank you, Dr. Sana. And so, yes, Doctor, I would also like to invite now Dr. Tariq to please give the certificate for the e-poster to Dr. Sana Said. Right, thank you very much. So next in line, we have the 4th standing position of Dr. Shagufta Ishtiaq, Jinas in Medical University and Dow Medical University. And the title was Impact on OBGY Training Considering Barriers and Facilitators During a Pandemic Situation. And I think she's online with us.
Yes, thank you so much. This study was conducted at Jinasin Medical University, and the other participants were Dr. Lubna Beg, Dr. Professor Halima, she's also here, Miss Mahjabeen, and Dr. Arisha. We explored the impact on the OBS and gynae training considering barriers and facilitators during a pandemic situation. This was a qualitative study, and we used the virtual IDIs for the trainees and supervisors. So the 5 major themes were emerged. That is, residents were feeling overwhelmed self, healthcare professionals observed strange behaviors, there was less training content, and everything was from routine to extreme. Everyone was feeling like to be a soldier in a battle. So we explored that there was a significant interruption in academic activities during this pandemic. The readiness and emergency response and implementing innovative training methods was surely insufficient. So we propose that the residency programs should address these gaps at institutional as well as at national level, and policymakers should come up with some feasible alternative trainings. Thank you so much.
Thank you, Shagufta. And let's move ahead with our 3rd number, which is Dr. Ikra Fatma Munawar Ali. She's from the Dean's Office, Khan University, and the title is Disparities in Patient Communication by Medical and Surgical Trainees, a Qualitative Study. And I think she's online with us. Oh, right, she's here with us. Oh, great.
Good evening, everyone. My name is Ikra Fatma. And so we conducted this study whereby we wanted to just know that what are the disparities that we can find within, like, by the residents. So for this purpose of the study, we made use of qualitative study set, like theme, and thereby we were able to gauge and understand how residents actually behave differently towards patients, depending upon their gender, socioeconomic status, cultural status, as well as the reception towards the treatment. And by the analysis, we were then thinking and hoping that it will be better if we are able to make few interventions that will help us to analyze further and make it clear that all the residents actually make sure that all the patients receive equal and fair treatment, despite of them belonging to different backgrounds, either social, economic, or having different genders. That's it. Thank you.
Thank you, Ikra. Well done. And so coming towards our, yeah.
So second we have today is Siptain Ahmed and pathology from and laboratory medicine Aga Khan University. And the title is Point of Care Testing Bootcamp for Year 3 medical students from bench to bedside. And do we have her with us? All right, so over to you, Siptain.
Thank you. Assalamu alaikum. Point of care testing, also known as bedside testing, was missing from the UGME curriculum at AKU. So in the recently introduced bench to bedside module for year 3, this was added as a half-day boot camp with the year 3 class split into 2 equal groups. The integral components of this boot camp were knowledge, skills, and the feedback. Knowledge was imparted through micro lectures, case-based discussions, and quick assessment of data interpretation skills. Skills were taught using glucometers, and there were individual performance by each student under supervision. It was followed by a competency assessment that was signed off for each individual student. And then there were pre and post-test quiz via Kahoot, and the post-test quiz revealed a statistically significant difference in the performance of the students. In the end, there was feedback on Likert scale of 5 point with 10 questions, 5 being the best, and 100% of the respondents were 4 or greater. And the whole experience proved to be fruitful. Thank you.
Thank you, Dr. Siptain, and please do not forget certificate. Yes. Right, so the final and the first, I would have to say, that's Dr. Sadia Abbas, medical student, Aga Khan University, a national virtual research training workshop for 3,800 medical students, a mixed method evaluation of a novel research education program.
Thank you, Dr. Sonia, for the introduction. Hello, everyone. Assalamu alaikum. I hope I'm audible. So last year during the COVID-19 pandemic, the Student Research Forum at the Aga Khan University conducted an online research training workshop titled A Beginner's Guide to Research, which was open to medical students all across Pakistan, with the main aim of exploring students' perceptions regarding engaging in such workshops, along with evaluating the effectiveness of such interventions. To the best of our knowledge, this was the first ever national research workshop in Pakistan, which was accessible to all medical students with an overwhelming turnout of more than 3,800 participants. According to analysis of the quantitative feedback surveys filled by the participants, around 84% stated that the workshop actually helped them to improve their research knowledge, giving them confidence to conduct research projects in the future. During the qualitative focused group discussions that we conducted, the main motivating factor that was identified for participation in the series was a lack of prior baseline research knowledge. So this series presented a way in which alternative pedagogies can be used for the dissemination of research knowledge amongst medical students who, as evident by this study, have a strong inclination towards research, but they feel and consider that the research exposure in official medical curriculum is inadequate. Thank you.
Thank you, Sadia, and a huge congratulations to all the participants of the Besties posters.
For the both best oral presentation. मैंने कहा मास्क उतार दो बहुत देर से सब बैठे हुए हैं ना. So the criteria used were based on the content, methods, results, discussion, delivery, slides. So सारा एक holistic approach की base पर the judges, you have seen 2 judges here and Dr. Zareen is there online, they marked, and based on that we identified 3 best oral presentations. And in order of ascending order, number 3, I'll start with number 3, Laila Akbar Qasim. And her oral presentation was on stakeholders' experiences of virtual instruction in post-RN baccalaureate nursing program during COVID-19. Laila Akbar, aap hain? Anybody can receive on her behalf? Aap from nursing receive, if you could receive. So number 2, based on the same criteria, mentoring experience and perceptions of mentors regarding mentoring program at a newly established medical institute, Dr. Javeria Rahman. And guess who would be the first one? A nationwide virtual research education program for 3,800 medical students in Pakistan. Methodology, outreach, and outcomes. Ali Ahil Noor Ali. So I think great. So this was great overall day. Just as a concluding remarks, Ravina Karamaliani ko aana tha, lekin she regretted because of she was not able to join today. So I think overall it was a great day where a number of excellent abstracts were presented. I'm really thankful to all the judges of oral and poster presentations. They did a really great job in marking, and the presenters for presenting such nice studies. And we want to build it into a conference next year, hopefully. And so that would be again a good avenue for us. हम हो सकता है कि ज़्यादा इसको face to face कर सकें next year. And I think the great thing this year was that the Students Research Forum से बहुत सारे abstracts आए, and I think that was good. And I think I would expect कि from nursing school के students के भी next year आए और भी ज़्यादा, so that would be great as well. And from residents and fellows उनकी तरफ से भी abstract आए, तो I think that would be great. So I think thank you so much everybody for joining and staying here till now. I would now ask Dr. Rahila, who is the co-chair of the research committee, to give vote of thanks.
Thank you, Dr. Tariq. And with this, we come to the end of the day. Thank you everyone for taking time out to join us. I hope you all had a very useful session, a useful time, and it was informative and worthwhile. I, on behalf of the Department of Education Development, would like to thank the President, Mr. Suleiman Shahabuddin, the keynote speaker, Dr. Muhammad Iraqi, the Dean Medical College, Dr. Adil Haider, for gracing today's event and taking time out to be with us. We also extend profound gratitude to all the speakers who shared their work with us. Thank you everyone for bringing in your experience and expertise today. Thank you to the judges who spared their valuable time to judge the oral presentations, Dr. Zareen, Dr. Ambreen, and Dr. Naveed Yusuf. And thank you to the judges for the poster presentations. Who were Dr. Jacqueline Dias, Dr. Iram Khurshid, Dr. Nusrat Fatma Rizvi, Dr. Nida Najmi, Dr. Farheen Yusuf, Dr. Alia Aziz, and Dr. Azam Afzal. Organization of such events results from close cooperation of many individuals. So first, I would like to thank Dr. Tariq and Dr. Zubairi for their guidance and support, and all the admin staff for their support in organizing the event and taking care of all the things going on behind the scenes. A very big and special thanks to Anil for his dedicated work. Day in and day out. Thank you, Anil. And along with Anil, I would like to thank Aslam, who took an excellent care of the webpage, Miran for compiling the abstract book and the videos, and Sundar for taking care of all the other things as well along with them. Thank you to the conference personnel from the conference secretariat, the IT services, the AV services, the electronics, the food service, and the administration of the medical college. And then last but not least, thanks to the department for their input and support, especially the department research committee, Dr. Sonia Heather, Dr. Tabassum Zehra, Dr. Shazia Babar, Dr. Javeria Rahman, and Dr. Leena Khan, without whose dedication and hard work this event would not have been possible. Once again, thank you for being with us today. Your presence helped to make this event a success. Thank you very much, everyone, and a very good evening. Exactly with 6:30. So that is the best part.